We are live now, ma'am. Good evening, esteemed faculty members and all the delegates. Thank you for joining. Today we are back with our series, The Benchmark, episode 13, and today's topic is medico-legal issues. So it's my privilege to introduce Neha ma'am, who is the program director of this webinar. And ma'am has been given more than 300 talks in state and national and international conferences, 25 plus articles, and also peer reviewer of Jogi. Ma'am has been the chairperson of Breast Committee Foxy 2019 to 21, Governing Council member ICOG 21 to 22, chairperson of Medical Disorders Committee of AMOX from 22 to 24, founder president of Vidarbha ISOPAG 2017 to 19, and also ma'am has been the president of Yavatmal OBGYN Society in 2007 and 8, founder clinical secretary of Yavatmal OBGYN Society, executive committee member of AMOX in 2020 to 22. And also, ma'am has
Okay.
been currently the chairperson of
Thank
AMOX
you,
Emergency
Saiti.
Obstetrics Committee. Yeah, I welcome you, ma'am, and I hand over the session to you.
Thank you so much, Saiti, for a very good evening to one and all. My my respect and regards to all the seniors here. My special regards to Madam Kamini Rao, who will be just joining soon, and of course the guest of honor for today's program, Dr. Prakash Pawar sir, Madam Anita Singh, and Dr. Gokul Das sir. All my mentors, a very good evening to all of you and welcome to this program. We're very happy to have Dr. Jyoti Banglowala as the expert for this program. She's the sitting chairperson for Foxy Ethics and Medical Legal Committee. I would like to welcome all the speakers, especially Dr. Dilip Warke, who will be speaking on death on table, Dr. Aarti Tandon, who will be speaking on the notice served, what next? Dr. Jamuna Devi, Madam will be speaking on MTP Act amendment, and Dr. MC Patel, sir, who will be speaking on the consent, uniform consent. So I welcome all the chairpersons as well, Dr. Ajay Mane, who is the past Vice President of Foxy, and Dr. Ashwin Rao, the youngster coming up. Madam Kamini Rao, good evening. Good evening. Very happy to have you and thank you for your blessings. We're just starting with the introduction and welcome from my side as program director. And I would also like to welcome the chairpersons, Dr. Girish Kumtekar and Dr. Gitika Jain, Dr. Alka Kuthe and Dr. Shamal Seth, Dr. Minakshi Deshpande and Dr. Girish Mane. So we have tried to cover the guests as well as the speakers and chairpersons from all over all the nooks and corners of India. So with this, I would like to welcome all of you. And of course, I would like to have blessings from Madam Kamini Rao, who is the chief guest for today's program. Sahiti, can we have Madam CV, please? So, I mean, I'm a very small person to introduce Madam, though it's as a formality, I would just like to say, Madam, as a former president of Foxy, I would say the youngest, and who has started the UA Foxes for all the zones of India. She's the founder chairperson, Medicine Academics and e-learning portal, and currently, she's the chairperson, National Register of ART Clinics, Banks in India, editor-in-chief, International Journal of Infertility and Medicine, and of course, member, National Advisory Committee for Drafting Guidelines in ART. Madam is Padma Shri, which we are very proud of, way back in 2014 in recognition of the distinguished service in the field of reproductive medicine, and she's the honorary fellow of International Academy of Human Reproduction based on contribution to the science of human reproduction and recognized international prominence in May 21. Madam, lots and lots of awards and accolades to your credit. We are very happy and privileged to have you, and may we have the words of blessings and guidance from you. Over to you, Madam, for your precious words.
Thank you, Sneha. I think that was very superfluous for me. I'm a very small person in this. However, I would like to say that it gladdens my heart to see Jamuna there with a lovely smiling face every time. I always tell her, no, her smile and her eyes light up every time when I was in Hyderabad, and I continue to say that again. And Gokul Das, of course, a dear friend of mine from Guwahati, and I have always seen him in his garden, and he always has that on Facebook as well. Of course, the legal part of it is different. Of course, we're now in the seminar, and a whole lot of other people here that we have, that is Alka Kunte as well as Geetika as well. Dilip Palke is another great friend of mine, and Ashwini Rao, and a whole lot of people here. It gives me great pleasure to be with you all today, because webinars like this is a very good way of spreading knowledge, and no gynecologist can be ignorant of law, because that is almost creeping into every field of gynecology, and particularly into obstetrics and gynecology and infertility. So I'm so happy to see so many people actually, deliberating on this subject and then getting updated on this, because unless you're updated, you become illiterate. And then ignorance is not excused in the court of law. And I'm happy that Sneha is doing this and then taking it forward, because once you are updated on this, then you can actually teach your students as well. Because the kind of people that we meet as patients today are well versed. Being Google doctors today, we find that we have to be, updated as well. Gone are the days when, the doctor was considered as God, and anything that they did, people would swallow. But today, the doctor is looked as a potential. Every patient is a potential litigant. So you'll have to be very careful. You have to cover yourself. So you need to make sure that the counseling is complete and they understand the pros and cons, and not to give them like everything is all right and 100% success. All these things will not work. So I'm happy to see that the varied speakers that you see are going to cover varied subjects in obstetrics and gynecology. And I'm very, very pleased to see that happen. And Sneha, all the best for the seminar and also for your elections, coming elections. I hope these things will also, turn out for votes as well. Thank you very much.
Thank you, madam. Thank you so much. Just to update you on this platform, that this is a platform where we select a focus topic every time, and right from early pregnancy, obstetrics, entire up to medical legal issues, everything we're trying to cover. And for this program today, all the who's who of ethics and medical legal committee of FOXY, from I think last 10 years we have tried to include. So I'm very happy and of course blessed to have you as chief guest, madam. Thank you so much for your blessing.
Actually, I should thank Sneha for making me meet madam. I'm so flabbergasted and happy to see you, madam.
Thank you. Thank you. Pleasure.
So,
always my pleasure.
Yes. Thank you so much, madam. With this, we move ahead with the blessings of our guest of honor, Dr. Gokul Das, sir. So, sir, I know him since so many years, since the beginning of my FOXY journey, way back in around 2000 or so. And yes, very inspiring personality, of course, very strict about his principles. That is what I know. I relate you, sir, very much. Sir is the past vice president of FOXY that all of us know, but a member of governing council, member of ICOG 2014-16, president of Guwahati Society, and of course I have had the pleasure of attending the AICOG 2010, and of course experienced your warm hospitality. Sir, apart from this, whatever is written here, sir is a very committed worker, I would say, or activist for women's health. And with this, we bow our heads, sir, and take this opportunity to listen to your precious words and blessings as well. Over to you, sir.
Thank you, Sneha, for your kind words. I'm very happy to join in this group. I'm very happy to see you because I have been knowing you from almost 2008. And you have been very active in the FOXY forum and doing your best to promote it. And you are really deserving candidate. for this vice president. And I really wish you all the best. And we definitely will support you. And today's subject is very relevant. And very happy to see the name of Prakash Pawar and Dilip, because I know them for last almost more than 15 years, I would say 20 years. So it's really nice to see them well. And we look forward to this discussion on this medical legal issues, because it is a burning issue for all the obstetrician and gynecologists. So wish you all the best and everything. And once again, wish you all the best.
Thank you, sir. Thank you
Thanks.
so much for your blessings and support always. With this, we would like to move ahead and have the blessings from Sir Prakash Pawar, sir, whom I know since a long time. And of course, sir is the practicing obstetrician and gynecologist for more than 50 years. And all of you know him as the ex-committee chairperson of FOXI, Ethics and Medical Legal Committee, and he has lots of accolades to his credit. Sir, we wish for your good health and of course well-being always. We just request you to bless us and guide us. Over to you, sir, Prakash Babu.
Thank you, Dr. Sneha. Thank you very much. And I'm very glad that I can see all old friends, Madam Kamini Rao, Dr. Gopadas, Varke, Kumtekar. There's so many things. And I remember Yavatmal conference where we had a very good discussion on medical legal thing. Now the days are changing. People read Google, Chatbot, and they come out with all the preparation that to bombard the questions and ask you if there is any complication. So it is absolutely necessary for the youngsters to know medical legal things perfectly and do the practice ethically and legally. Thank you very much and all the best for your coming election.
Sir.
I hope you will succeed this time, definitely. Thank you very much.
Thank you so much, sir. I have been working for I would say all the committees and all the fields of FOXI since more than 20 years now. And I'm trying my best with honesty, hard work and perseverance. And with your blessings, I just hope that it happens. It's my passion that is continuing my, work ahead. So thank you so much. With God's blessings and all the respected seniors' blessings and guidance, we would like to move ahead with the academic session. So thank you all of you for, gracing this program and blessing all of us. Thank you so much, sir. So Saiti, we would like to go ahead with the first session. And yes, I would like to invite the chairpersons, Dr. Ajay Mane and Dr. Ashwin Rao, for the first talk by Dr. Dilip Varke. So I hope Dr. Ajay Mane has joined, because I think in 2 minutes he was supposed to join. I will introduce Dr. Ashwin by the time. Saiti? Yeah. So Dr. Ashwin Rao is a young friend of ours from Salem, and he is the practicing obstetrician and gynecologist. So he is serving in the Mahatma Gandhi Medical College, and he is received his fellowship in reproductive medicine from D.Y. Patil Medical College. He also has his fellowship in aesthetic gynecology and his postgraduate diploma in medical legal systems, that is from Symbiosis Pune. So we are very happy to have you, Dr. Ashwin. Welcome to this program. And
thank you, ma'am. Thank you for the kind.
Yes, welcome. So can we have the CV of Dr. Ajay Mane? So Dr. Ajay Mane is the immediate past vice president of FOXI, and he's also the medical legal consultant since last 20 years, chairperson of official.
Sir, webinar मध्ये माझा talk सुरू होतोय आता.
Yes, and chairperson of
झालं की निवांत झालं.
amongst. Yes, so welcome Dr. Ajay. Welcome, Dr. Ajay Mane. We have already introduced you. We're very happy to have you. And I now hand over the session to you for introduction of the speaker, both of you. Welcome, Dr. Ajay and Dr. Ashwin. Over to you.
Shall I introduce, ma'am?
You can introduce, yes.
Thank you so much for the opportunity, ma'am. I would like to introduce Dr. Dilip Palke. It's a great pleasure to introduce sir. He is a consultant, Jupiter Hospital and MediPoint Hospital, Pune, Chairman, Ethics Medical Legal Committee, 2007 to 10, President, Pune OB/GYN Society, 19 to 20, co-author of Foxy Uniform Consents, and advisory member of Dr. Prax Telemedicine Solutions. Thank you, sir, to this session.
Yeah, thank you. Thank you very much for a kind introduction. And can you hear me? Two usual questions
Yes,
when
sir.
it comes
Yes,
to.
sir. Yes, sir.
Yes.
And the next thing would be, can you see my slides?
Yes. Ajay, would you like to say something about the topic, or you would like to conclude the session?
No. When Dilip sir is there, I don't want to say anything because I'll give
नहीं नहीं
vote of
अजय प्राइवेट में बहुत बात करता है ऑन द वेबिनार ही विल नॉट से
नहीं अरे Dilip sir is there. अरे boss is boss. So I'm very happy to be chairperson in your session. Nothing to be said.
Thank you, Ajay, very much. So I think we'll get started. Thanks, Neha, because Neha, you have given me a chance to meet all my old friends, to meet Madam Rao, to meet Dr. Gokul Das, Dr. Prakash Pawar. After so many years, I'm becoming a little nostalgic about Foxy, good old Foxy days, and also to meet Ajay, Girish Mane, Girish Kumtekar, Alka, Meenakshi, Dr. MC Patel. I mean, thank you very much for that, and I hope, Alka, this time, Sneha, this time you will cross the finishing line, and this time you will be the vice president of Foxy, definitely, and we are all there to help you and guide you in that.
Thank you.
So I'll get started with the agenda. What we'll do is we'll consider a fictional situation of a small 5-bedded nursing home where you're doing an LSCS and there is a PPH and there is a cardiac arrest-like situation, a near-death situation. Let's not talk about death, but a near-death situation. And then we'll go ahead and try to find out what are the tips for medico-legal safety in such a case. Now, the biggest issue in death on table, especially in obstetric cases, this narrative. And the narrative is that nothing can go wrong in a young female during the process of delivery. So this is what people feel. And what they feel is if there is a mishap, then it is always because the doctor has goofed up the case. So we have to do something to change this narrative. And to change this narrative, we can do things on individual basis and we can do things on Foxy basis. On individual basis, we always encourage our patient. ना जब भी patient पूछता है कि is everything okay, we try to tell them yes, चिंता मत करो, सब कुछ ठीक है. And on the from the organization point of view, we never speak on things like the mortality or morbidity with a postpartum hemorrhage or an amniotic fluid embolism or shoulder dystocia and other unforeseen high-risk obstetric conditions. And that's the reason why the least we can do from now on is to that at the level of Foxy, have talks, articles, statements on the unforeseen in obstetric condition, and the unforeseen are the postpartum hemorrhage, the amniotic fluid embolism, and the shoulder dystocia. And at an individual level, start using the ready-to-use, almost fully informed consent that we have already devised, and that they are there on the Foxy website as Uniform Foxy consent. Dr. MC Patel is going to speak on those consents, but then I will tell you that they are almost informed because they capture all the possible complications and that can occur even in a normal vaginal delivery or even in a LSCS, so that the patient or the relatives can never say कि हमको कुछ बताया ही नहीं था. So this narrative that every time everything is going to be okay should gradually keep on changing. Now, having done that at a national level, what we should do is to change the narrative that every time delivery is going to be successful. But what today we are going to discuss is what do we do at the ground zero level. So this is what today's talk is all about. The tip number one is that death on table or death in a labor ward does not always mean negligence. This is what you have to understand, and you should not be panicking in such a situation, because what happens is when this case goes in the court will try to find out Number one, who managed the labor? Was he qualified? Was the doctor who conducted the delivery qualified, or the doctor who gave anesthesia was qualified? And did they act in a way that an averagely skilled person, an averagely skilled gynecologist or an averagely skilled anesthetist would have done? They did that or would not have done, and they did not do that. If that is proved, that means they have taken a reasonable care, and despite that, if there is death, does not mean that there is negligence. So this is what you have to understand, that just because there is death, you're not going to be considered to be negligence. Tip number 2 is relax and resuscitate. It's very easy to say relax and resuscitate, but at that moment things become very difficult. I feel that the anesthetist is the best person, best qualified person to do the resuscitation. And that is if the anesthetist is available in the labor room. Let the anesthetist or take charge of the situation. And if the anesthetist is not available, then somebody who has got certificate of advanced life support. So these certificates, your staff having these kind of cardiac care support or the basic life support certificates are important. When the case goes in the court of law, that is the time you'll have to prove that the person who was resuscitating was indeed qualified to resuscitate. So this is the important carry-home message that you should have. Then when you're talking about the equipments or drugs for resuscitation, Dr. Pawar will be with me when I say that when we used to go all over the country and give talks, in those days we used to say that minimum a small nursing home should have is a Boyle's apparatus and a defibrillator. Now when we go one step further and we say that the minimum that a small nursing home should have is an anesthesia workstation with a CO2 absorber and a capnometer. Because now you're doing even laparoscopic surgeries in a small nursing home. And what happens is, because an anesthesia workstation is essentially a ventilator, then in the court of law, you will be able to defend that till such time that the cardiac ambulance arrived, my hospital was equipped enough to have a ventilator. So that becomes one good defense for you in the court of law. So everybody, it's a matter of spending about 6-7 lakh rupees in your operation theater. So buy your Mercedes a little later, but buy an anesthesia workstation first for your nursing home. Then we can have our emergency tray, like just as corporate hospitals have their crash card, we can have an emergency tray so that you have to just say, sister, get the emergency tray, and you will get everything, including emergency drugs, IV fluids, IV sets, blood sets, intracat syringes, needles, emergency injection, emergency tablets, even sitting plaster, scissors, ampule cutters, oxygen cylinder, pana, everything. Everything should be there in that emergency tray, etc., 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 and a laryngeal mask. And I'll tell you, when I was the president of the Pune Obs and Gynec Society, the one thing I was doing was I used to keep an intubating mannequin outside the hall when any of the delegate was entering for a talk. That delegate, after having signed, was supposed to put in an LMA in that intubating mannequin and only then enter. And when I started doing that, everybody, almost about 30-40% of my delegates bought a laryngeal mask. So each one bought one laryngeal mask. And I can tell you at least 2 cases in Pune that the patient could survive because the doctor, the gynecologist, can put in an LMA till an anesthetist arrived and then intubated the patient. Laryngeal mask, inserting a laryngeal mask is as simple as putting in a urinary catheter. So I think every nursing home, every small nursing home should have a laryngeal mask. So never ever in the court of law you will be will the opposite lawyer be able to prove that this hospital was not equipped to manage the respiration of my patient. Then document your resuscitation, because we always, as medical legal experts, we always say that a good document is a good defense and a bad document is a bad defense. So what I say is, have printed and laminated protocols for cardiac arrest and anaphylaxis management, printed, laminated and pasted on the wall. If you are not allowed to paste it on the wall of your nursing home, then at least keep it on your trolley. So if these are there, then whenever there is a problem, you will do what you best you can do. But when you're making your notes, you will not miss out on anything, because everything will be written there on the in the protocol. So when you're actually making the notes, your notes will be complete. So you can just copy and make notes and will not be missing anything. No expiry date drug. So if your nursing home or your OT, I know of a case where a patient died during tubectomy, and actually the patient was not done under GA. The patient was actually managed under spinal anesthesia. But when the police came, they found one ampule of scoline which was post-expiry. So no post-expiry date drugs in your operation theater and your labor room. Be very vigilant about these things, because if whenever there is a problem, then the police knows only two things. One is ऑक्सीजन सिलेंडर भरा हुआ था कि नहीं, और जो भी ड्रग्स वहां पड़े हुए थे वेदर दे वर पास्ट एक्सपायर. तो ये दो चीज वो आके चेक करेंगे. So be very vigilant on this. No prescription of life-saving drugs to the relative, because that only proves that your hospital was not equipped and then you were lacking in those life-saving drugs. So if there is a situation wherein you do not have a life-saving drug, then call up a friend. Say if you are in Aurangabad, then call Ajay Mane. Arey Ajay, मेरे hospital में ये drug नहीं है, तू लेके आ, because there is a problem. But don't give that life-saving drug prescription to the relative, because then the relative can produce in the court of law saying that this life-saving drug was also not available in this nursing home. So I always tell about this case in from Pune, where there was a cardiac arrest in a case of LSCS, and the doctor had given a prescription for a battery cell for the pulse ox that they put on the finger. Now, this person has produced that prescription in the court of law, and he is now saying that if this doctor did not have a battery cell to monitor the oxygen saturation of my patient, how can he actually manage my patient? So these kind of prescriptions are very dangerous. Be very careful about giving such prescription. Call for help. Rushed in concept is there many a time. Many of the medico-legal consultants, experts must have told you about this concept. But then the immediate reaction is phone is jhamele mein padega. But let me tell you, this Good Samaritan law may not have been passed yet in our country, but it is pending in the Lok Sabha. But usually, any of the judge will hold a Good Samaritan to be negligent only if he does palpably wrong. So if somebody is doing a section and there is postpartum hemorrhage, and if you are called there and you went there and you helped, and despite you helping there is a death on table, you will be considered negligent only if after you went there, whatever you did was palpably wrong. So don't be afraid of somebody who afraid, and if some junior is calling you for help, I think everybody should go there and help that person, also clinically, and also to tide over the situation of a mob frenzy that can occur after a death on table. Communicate your staff with your staff. See, I always say that before you start communicating with the relatives, first thing is you communicate with your staff, because the moment there is a problem, there is a tendency that the relatives will ask the mausi, the aya bhai, the staff nurse, andar kya hua? So it is better that you call everybody inside the room, call the staff nurse, aya, metrani, receptionist, everybody, and tell them what happened and why it happened, so that when they talk to the relatives of the patient, they will talk in sync, and one person will not give one thing and the other person will not. I mean, somebody says there was postpartum hemorrhage and the other person says that there was amniotic fluid embolism, and the third person says कि injection ko reaction hua. This will be very wrong. So you first decide the defense that you're going to take. Tell that to your staff, and the staff should be talking in the same way with the relatives. Even if you're closing a dead patient, close with a proper mop count, because first thing is there is death on table, and second, if there is PM done and they found that there was a mop inside the dead body also, then it can have a very negative effect on your case. So even if you feel that this patient, I mean, it's very easy to say, but when actually you're facing that, it becomes a problem. But be careful. Close that dead body as if you're closing a proper living patient, and see that the mop on when the instrument count and the needle counts and everything is okay while you're closing this dead patient also. Shifting the patient to a tertiary care hospital, there are two situations when you would want to shift the patient. One is after the death, and second is before the death, where the patient is now so serious that you feel that the patient needs to be shifted. Now, after the death, in good old days, the advice used to be make a show that the patient is alive and shift this patient to an ICU and then declare death later on in the ICU. In the present day, with the technical advances, the risk of being caught and accused of forgery is very high because there are monitors which is monitoring the patient while the patient was under anesthesia, and that there was a flat line will be shown at the time when the patient was inside the OT. So please don't get into all that, because if you are proved to be having done a forgery, then the only thing that you will have to face is an arrest. But if you are proved to be negligent, the maximum thing that can be happening to you will be that you will be awarded a compensation. So it is better not to do a forgery, but tell the truth. And if the patient is very serious and you want to shift the patient before the patient is dead, then you have to take a joint decision with the physician, with the surgeon, with the neurosurgeon, whosoever who may have come there to help you. You should shift a hemodynamically stable patient, not too early and not too late, because if you are shifting it too early and shifting it too late, then during the transit there can be a problem. So take a decision whether this patient is good enough to be shifted in the ambulance. The doctors who are trained in resuscitation, again, the importance of having a BLS and a ACLS training certificate, should be accompanying the patient with all the resuscitative drugs and all a very well equipped ambulance, so that you will be able to prove that even if there was any problem during the transit, my doctors were there, my ambulance was good enough and well equipped to handle the problem there. Transfer with a proper transfer note. Choose the closest center of patients or the relative's choice. And if the choice is left to us, then choose the center where you have a rapport. I mean, where you have a rapport with the ICU doctors there and the patient is not affording, then you have to shift to a government hospital, and the government hospital will never be able to refuse this patient. A consent for transfer, if there is time, if you have time to take a consent from the relatives for transferring the patient, take this. But if there is a dire emergency, this consent is not as important as taking a consent of for doing an elective surgery. But if there is you have time, then you do take a consent for transfer of such a patient. Then you have to complete the paperwork, and the paperwork, I mean, the note should not be too visibly manipulated, not too perfect, no omission of obvious steps, no contradictory notes. I mean, somebody saying that it is PPH, the physician says that it is PPH, and the gynecologist is trying to defend it as a case of amniotic fluid embolism is not done. You have to be very careful. Absence of consent, and now the patient died. I mean, you forgot to take a consent and the patient is on table and the patient is dead. Don't have this habit of taking the thumb impression of the dead patient, because that again amounts to forgery and it should not be resorted to. So complete this paperwork. Set the OT in order, because now the police is going to come. So set the OT in order. I mean, what I am telling you here may be seen by somebody as erasing all the evidence of the crime scene, but maybe you can take it off the dais advice, but clean the floor of the blood stain, because for you the floor is just blood stain, but for the relatives it is that the patient bucket bhar ke bleeding ho gayi. That is the kind of reaction they have. So clean the floor, dispose the drapes stained with blood. Check the equipment, especially the oxygen cylinder, because when the police come, they are only trained in finding out whether the cylinder was full or not. See that the IV lines are patent. See that the catheters are in place. See that all the material that you have used are saved properly. Check the expiry date of all the drugs that have been used, and check the endotracheal tube. And when I say check the endotracheal tube, initially I used to say that check whether the endotracheal tube is in the trachea. Now I say, before the police arrives, remove the endotracheal tube and keep it aside, because in one of the cases in Bombay, Dr. Prakash Pawar may be knowing it, the doctor checked that the endotracheal tube was inside the trachea, and when the dead body was being shifted from the OT table to the shifting trolley, that endotracheal tube came out of the trachea, and later on while doing PM it was said that the tube was in the esophagus. So please, now the new advice that we are giving is remove the endotracheal tube and keep it aside. There is nothing against doing that before the police arrives. Inform the relatives about the problem. I think this is a ceremony that has to be done properly. You have to time information that the patient is sinking, and we are doing what we can do for the patient. I've called this doctor, that doctor, all that you have to keep on doing. And whatever is seen in a Hindi movie that you come out and say that patient is no more, is not done here, you have to slowly build it up. And it has to be, this communication has to be done by a senior with a proper communication skill. It is very nice for me to say be polite, be patient, be sympathetic, but be assertive. But you have to have that seniority and halo around you to be able to be sympathetic, but at the same time assertive, polite, but at the same time be very assertive about the content of what you are saying. And of course, no blame game. The surgeon should not blame the anesthetist. The anesthetist should not blame the surgeon, because the moment you do that, Dr. Prakash Pawar, Dr. Girish Kumtekar, and everybody who are medical legal experts will agree with me that the moment you start playing the blame game, it is a victory for the opposite lawyer. And of course, you have to be prepared for the mob frenzy if at all it occurs. Then there are 4 questions which are always asked whenever there is a death on table. Number 1, should all death on tables, including maternal deaths, be informed to the police? Number 1. Number 2, who has the onus of asking for MLCPM? Is it the doctor or the police? Number 3, if the cause of death is known, example PPH, even in a maternal death, can we give even in a medical legal case, can we give a death certificate even for maternal death or a medical legal case? Question number 4, can an appropriate authority doing a death review pull us up for not doing PM in a case of maternal death? I mean, can they say that you were negligent? I mean, whether you were negligent or not negligent, is it their duty? That is question number 4. And the question number 5 is this undertaking that we used to take from the relative that we have nothing against the doctor and nothing against the hospital, is it helpful? So these are the 4 questions. I will take that one by one and then I'll stop. The first one is police information. The fact is there is no statutory law in our country which forces us to inform all death on table to the police. For example, if you are doing a ASA grade 4 case, say you're doing a cardiac surgery and if there was death on table, then do you think they should be informing this to the police, every death on table, when you're doing a grade 4 anesthesia surgery? No. But in our case, because our obstetric patients are young and they are not expected to die during labor or LSS, and since we are likely to be one of the accused,
I think some network issue with Dilip.
I think it's freezed.
Yeah. He will join back, I suppose. Some network issue.
You can call
Yeah, that is what I'm doing. But welcome, sir. Good evening, MC Patel, sir.
Good evening.
Namaste. नाही, परत एकदा ट्राय करून अच्छा, just 1 minute so that we also thank you, but somebody has some comments, please join. He's got some network issue. I think he's unable to join. That is what he's saying. But for a moment, we wait for him. Otherwise, we can have chairperson's comments. So, Dr. Ajay, please make few comments by the time Dr. Dilip joins.
Yeah. I was trying to call him because he need to complete his talk basically.
He said it was the last slide, but then it's okay.
But I appreciate his points. I'll reiterate some of the points which he insisted. must be done. The list is must be done, because see, everything can be managed, but in such situations, a few things are to be done at that moment only. Because the police, they don't give the time, though the law says give 72 hours to all of us to complete the paper, to complete the situation, everything. Prakash Pawar sir is very senior to all of us. He must have faced very different situations than all of us, because when he was in full swing, there were no social media and nothing, and no support from other people also. But nowadays we can have one press button, and so many people will come for all of us. But I'll tell few of the points which Dilip sir told, and he has completely he is
Very
back.
good. Yeah, he's joining back, and I think with connecting to audio.
Yeah, Dilip sir,
Welcome
Bola.
back.
I
Welcome.
think I was in the last few slides, so I think we'll finish the
परत
presentation. If there are
चालू
any
कर.
questions, I can take it.
Please,
नाही नाही, परत
please
चालू
go
करा
ahead.
ना तुमचं. तुम्ही
परत चालू करण्यासारखं काय नाही आहे.
No,
information
no,
पोलीस
Dilip, you had 4 points to be discussed. I think those points to be discussed will be beneficial to the delegates
okay.
who are listening. Yes.
you start your
Just a
presentation
moment.
again. Information to
करतो.
police was the topic which you were telling us.
एकच मिनिट थांबा. आय जस्ट डू द प्रेझेंटेशन. उघडतो प्रेझेंटेशन.
Due to this cloudy things and all the things,
I think last 5 points were there.
I'll take those points and then we'll
Yes.
finish.
Yes.
Just a moment. I'm not very savvy with all this. I'll try to share the screen. Can you see my screen?
Yes.
येत आहे?
हो दिसतंय.
दिसतंय ना? मी परत आता I'll just go ahead. I'm sorry, there something went wrong with my internet.
नाही ते सगळीकडेच प्रॉब्लेम आहेत. इंटरनेट इज बिट प्रॉब्लेमॅटिक ऑल ओव्हर.
आता आलाय, बायको म्हणाली आलाय म्हणून. So I'll take these 4 points and then we will stop. The first point was police information. So the first thing is whether every death on table is to be informed to the police. And the answer is there is no statutory law which forces us to inform every death on table to police. Because supposing if a cardiac surgeon is operating on a grade 4 ASA patient, anesthesia patient, then do you think he will have to inform every death on table to the police? Answer is no. But here in our case, since our obstetric patients are young and they are not expected to die in labor or LSS, and since we are the ones who are doing surgery and there is a possibility that somebody may have a suspicion on us, it is better to call the police to investigate whether there is any negligence or not. Definitely we should call the police if there is a possibility of a mob violence. Which comes to our second question: who is the one who's supposed to tell the relatives that we have to send the body for medical legal PM? All these years, what we used to do is used to take the onus on us. पेशेंट की हम अभी ये पेशेंट का डेथ सर्टिफिकेट दे नहीं सकते, आपको ये बॉडी मेडिको लीगल पीएम के लिए लेके जाना पड़ेगा, एंड देन देयर यूज्ड टू बी अ मॉब वायलेंस. द फैक्ट ऑफ द मैटर इज इट इज द ड्यूटी ऑफ द पुलिस to decide whether there is any suspicion and whether there is any kind of whether the death certificate cannot be given and this body has to go for medico legal PM or not. Which comes to the next question: can we give a death certificate if we know the cause of death? Like in this case, the patient has died because there was multi-organ failure, because of severe hypotension, because of postpartum hemorrhage, probably because of placenta previa. Don't we know the cause of death? So again, there is no statutory law which prevents us from giving a death certificate, even in a maternal case, if we know the cause of death, even in a medico-legal case. Only thing is, when we are giving a cause of death in a medico-legal case or this kind of a case, then we have to give the death certificate to the police and not to the relatives. But again, because our patient is an obstetric patient, a young patient, not expected to die in labor, and since the court believes the cause of death given by the postmortem surgeon more than the cause of death that is going to be given by us, it is better to tell the police, manipulate the police, and ask the patient to police to tell the relative to take the body away for medico-legal PM. Which of the dais, I need to tell you that if you are confident that you have not done anything wrong in the case, if you are confident that the patient has died because of no negligence of yours, and if you know the cause of death, be bold and give the cause of death. Tell the police that if you say I can give you the cause of death, but if you feel that the relatives are suspicious, then you can take the body for medico-legal PM. Again, when this case goes to the appropriate authority, don't be afraid to face the appropriate authority. The appropriate authority is not an authority to judge whether we were negligent in the case or not. They are not the ones who should be asking, blood ka arrange killer, why did you not give the death certificate and things like that? Why did you start a pitocin rate? Why were you not monitoring the pitocin? That is not their job. Their job is to just find out whether things like whether the patient was staying near the hospital or not, whether the patient had taken iron tablets or not. So they are only to help the government of India for all those healthcare decisions. So they are not supposed to judge you for negligence. So face them properly without any tension. And which comes to the last question. We used to say as medico-legal experts, ये जो हम लोग लिख के लेते हैं ना from the relatives that we have no complaint against the doctor and the hospital and we would like to take the body away for cremation, इसका कोई value नहीं है. It is not going to save you in the court of law. Yeah, it may not save you, but it may save the police who may have decided not to take the body away for medico-legal PM, because then in the court of law, the police will be able to say कि relatives had no suspicion against the doctor. This is what the relative had given to me in writing. So that written document in your indoor paper may not help you, but may help the police in his decision of not sending the body for medico-legal PM. And then your cause of death, the court will have to accept. So these are the things. See, you should be knowing your rights, and then the decisions that are taken are as per the situation that is there on the ground zero. There cannot be a straitjacket answer saying that DC de hi nahi sakte ya DC de sakte hai. There cannot be a straitjacket answer. So whenever you are facing such a situation, call people like Ajay Mane, call people like Greenish Kumprepper, call people like Dr. Prakash Pawar, and take a conscious decision which you can defend yourself in the court of law. So don't get carried away and have a very straitjacket answer. I think this is what it is, and I think I'll stop at this because I've overtaken my time. You can ask questions if there are any. Shall I stop sharing?
Yes, yes.
Yes, very nice, Dilip sir. You have covered more than the points desired from all of us. So everything is clear in our mind. So thank you very much. It was very nice lecture. And I like one of your advice that you told about you insisted about that CO2 absorber and capnometer. It is very nice advice. It's the best advice you have given, because nowadays the government has made compulsory to have defibrillator and oxygen boils apparatus. It is mandatory, which was not mandatory when you are advising. Now you have advised these two things, and in incoming days the government can make it compulsory, CO2 absorber and capnometer, because the
not only Ajay, it is clinically important for those
Correct.
who are doing laparoscopic
Correct.
surgery. For me,
Correct.
medico-legally also. See, basically, anesthesia workstation is basically a ventilator. And the usual problem in our defense when we are defending a small nursing home in the court of law is that your nursing was not having infrastructure to manage this serious patient. Now we
Correct.
will be able to prove that mere paas ventilator tha. See, I was ventilating the patient on a ventilator. Even if you are bag masking, that bag masking ko value nahi hai. In the court of law, you should be able to prove that there was a ventilator. So you will be able to prove that I was ventilating till the cardiac ambulance came, and I just shifted the patient from my ventilator to the ventilator in the cardiac ambulance. So that
Yes.
will be, you will be able to defend yourself much better than otherwise.
Yes, 100%, 100%.
And it is costing 6 lakhs rupees. And I think if everybody in Aurangabad, all small nursing homes in Aurangabad want to buy it, I think they will start giving you for 4 lakhs also.
Yeah, bulk purchase will help
Bulk
us.
purchase
And
karo.
basically, it is very less than the compensation, obviously.
Much less than the compensation. अपना गाड़ी थोड़ा डिले करो बॉस.
चलता है.
हाँ, BMW बाद में लेना आ जाए.
नहीं
पहले
सर,
ये ले.
बाकी लोगों से तो that is very nice. And then O2 checklist, that emergency tray checklist, no emergency prescriptions. And then maternal death review. You said it correctly. Maternal death review. They are there to discuss the situation only. They are not there to blame us, and they cannot file any complaint against all of us. That is, you said it correctly, sir. Thank you very much for the best lecture, sir. Thank you very much. And at the end, I must wish Sneha Tai all the best. And this time you are 100% a winner from all of us. Thank you, ma'am.
Yeah, Sneha, you have reached the finishing line now. It is only that one step and you will cross it.
Thank you so much. Thank you so much. I'm trying hard with all of your blessings and support. Yes, it should happen. Thank you so much, Dilip. That was excellent. I'm sure, every obstetrician, whosoever has faced it in any time in the life, I think it's a unforgettable moment, I think, and you have guided it so well that those who are, likely to face, they should be aware of everything what you have said. And yes, definitely.
And Sneha, at such times, you are there, I am there, Dr. Prakash Pawar is there. Please give us a call, because I don't want somebody to take the step that the doctor in Rajasthan had taken. Because if you have a death on table and if you're worried so much, somebody who's got a weak mind, and I know what you go through, because I have also faced one death on, not death on table, death on the third day. And I know, despite being a medical legal expert, what you go through psychologically is something very different. It's very difficult to describe in a lecture. So at such times, people like us are there. You just give a call. We will come and sit there, because now we are retired. You call me at any time in the evening, and somebody in Pune can call me. I'll come and sit with you. Not only I'll give you medical legal advice, but just to hold hands and see to it that you don't take any drastic steps like that. That is what is Foxy meant for. And I think, Sneha, when you go up the ladder, you will see to it, it is not just about conferences, not just about organizing these holiday trips to various places all over the world, but it is about holding hands with our members also.
Yes, that is what we are, that's what you said, that age old or good old days of Foxy. I think it's time to come back. So that is how. Yes.
And these the people who are attending now, like Dr. Kamini Rao, Dr. Gokul Das, these were the people who were not interested in those conferences. These were the people who were interested in developing that bond with the delegates. So bring it back to Foxy. I look forward to you getting that culture and that the whole essence of being a Foxian back into our society.
Thank you so much. I think Ajay and me, both of us take this point also ahead. We keep it in mind. Thank you so much. And let us move forward for the second session now. So, Saiti, can we have, chairperson, we have Dr. Girish Kumtekar, sir, from Solapur, who is a senior practicing obstetrician, as well as, very excellent medical legal consultant, and who, as you said, Dr. Dilip, holds hand, not only for the medical legal reasons also, but to, for the clinical, whatever help is required by the obstetrician. So welcome, Dr. Girish, sir. Sir is actually... So you have the CV is highly decorated. I would just welcome you by saying, yes, you were the member of Medical Legal and Ethics Committee, past member of Medical Legal Committee of IMA branch also. And we have heard you so often in talking about various, talks on the medical legal aspects. So with this, I welcome you as chairperson. And I welcome Dr. Gitika Jain from Bikaner, who is also the head of department and senior consultant obstetrician gynecologist, and she's a sonologist with special interest in fetal medicine. She's also the legal advisor to Upchar and lead assessor for Foxy Manyata. So Welcome, Dr. Gitika, and I hand over the session to you to introduce Dr. Aarti Tandon, our speaker for today. Over to you, Dr. Gitika.
Thank you so much, ma'am. Am I audible?
Yes, sure.
Okay. So thank you so much for inviting me to this for chairing this session. And I am thankful to all the senior and all the experts who are on this dais today. So I would like to introduce our esteemed speaker, Dr. Aarti Tandon ma'am, who's a DGO, DNB, MNAMS, and PGDMLE from National Law School, Bangalore. Ma'am is a senior consultant obstetrics and gynecology in Noida. She's a medical legal expert. She's also a visiting consultant in Cloud9 Hospital, Motherhood Hospital, and New Hospital. She has advanced training in infertility from Hong Kong. She's part of the organizing team of NOGS since its inception. She is also the invited faculty in national forums on medical legal subjects, and she has many publications to her in her kitty. The Obstetric Gynecology Statute Snapshots, Keeping Pace with Legal Changes and Recent Advances in Obstetrics and Gynecology, Volume 3. The Medical Legal Issues Dealing with Fetal Growth Restriction in AOGD Bulletin, Volume 3, in November 2023, Issue 6. So, ma'am is going to speak about what happens when the notice is served, what next? So when notice is served, mostly what happens is the doctors, they go in panic. They think there is some allegation which is there and the party is going to claim something, or they have some demands. And in panic, they often either reply very quickly without consulting any legal counsel, or in panic they don't even take the notice. Sometimes they don't try to receive the notice, which is not right. So I think I would hand over the session now to Dr. Aarti Tandon ma'am. So she would tell us more about what should we do when a notice is served.
Thank you very much for this introduction, ma'am.
Yes, welcome, madam. Welcome.
Thank you very much, Dr. Sneha and Dr. MC Patel, for having given me this opportunity. Can I just share my slides?
Yes.
Can you see it, please?
Yes. Just make it full screen, madam.
So, dear friends and colleagues, today's topic for discussion is notice served, what next? Vedic literature lauds doctors as Vaidyo Narayana Harihi. But gone is the time when doctors were considered gods. Medicine has its limitations and we cannot cure or satisfy every patient. No patient or relative is prepared or ready to accept a negative outcome. Despite a doctor's best efforts, even after a positive outcome, you can still be served a legal notice. Doctor is a warrior, battling with legal notices, illogical laws, disgruntled patient or relatives where there is a negative outcome, skyrocketing amounts of compensations, and increasing violence against doctors. So when you receive a legal notice, it's easier said than done, but stay calm, don't panic. Breathe in, breathe out, and take the help of stress busters. Let us first understand what is a legal notice. Legal notice is a formal written communication between two parties where the sender is notifying the recipient about his intention to take him to court. And the receiving party becomes aware of the grievances of the sender, that is basically many a times the patient. There may be a number of reasons for sending a legal notice. The first and foremost is when the patient is dissatisfied and disgruntled. When there are a number of complaints during treatment. When the hospital claims that there are facilities of laboratory facilities, MRI, scanning, 24-hour emergency, but there is a lack of facility which was claimed to be there. Whenever there is a negative outcome or adverse consequences, or there is a worsening of condition, or the patient is not getting better, or there is a death of the patient. Whenever there is a pressure to reduce the billing charges, there is an aggressive and violent behavior of the patient. There is a communication gap between the doctor and the patient or relatives where the doctor has not been able to put across the gravity of the situation. When the patient has asked you for medical records, but you have failed to provide those medical records within a time period of 72 hours, and then it is just your bad luck or your destiny that you are served a legal notice. This legal notice contains the name, description, address of the sender of the notice. What is the cause of action? Basically, what is his grievance? What is the kind of relief which he is claiming? What kind of a compensation he is asking for? And under what section is this compensation being asked for? So whenever you receive a legal notice, note the date and time of the receipt of notice, because you usually get a time period of 15 to 45 days to reply to a notice. You may get this notice several years after the discharge of a patient, even when the patient has gone back extremely happy with you, has served you sweets, given you chocolates, and said a thank you 10 times. And depending upon the way you answer to this notice may or may not culminate in a case. You can receive this legal notice from a disgruntled patient, from relatives, from the consumer court, from an advocate, the professional regulatory body, voluntary organizations, Human Rights Commission, government or regulatory authorities like the MTP, PCP, NDT, ART, surrogacy boards, and even from the Chief Minister, Prime Minister, or the President's office. All are demanding compensation for the alleged negligence on the part of the medical practitioner, or the faulty treatment given, or in case of death of the patient, and asking for detailed explanations regarding the treatment given. A notice can be delivered by hand, by courier, by post, by email, and since the COVID times, even through a WhatsApp or an SMS. There are basically two kinds of notices. One is a statutory notice and the other is a non-statutory notice. Now, the statutory notice is basically sent from a government authority or from some office or a regulatory board. For example, the Professional Regulatory Board, or it can be a summon from a consumer court or a civil court. It can be a notice from a government authority like the MTP authority or the ART board or the surrogacy board or the PCP-NDT board, or from the Human Rights Commission. And a non-statutory notice will come from the patient, relatives or guardian, and may even come from their advocate. So a very pertinent question is that, is it mandatory to reply to the notice? So the answer is no. But it is always preferable, because not responding can be taken as an admission of guilt, and the court may take adverse inference against the defaulting party in case this case goes over in the court. So the thing to be understood is that a legal notice is filed only in civil cases. And here the patient is wanting an answer from you because of the adverse consequences which have occurred, or want some kind of a compensation for you. Because in case it is a criminal notice which comes to you, it is an FIR which is filed in the police station, and the police is going to come to your house to arrest you. Legal consequences of legal notice depend upon the fact that it is delivered. And in case the legal notice remains undelivered because the party refuses to accept it, then it goes against him. So when you receive the legal notice, take your time to respond to the notice. Don't be in too much of a hurry, because you are in a panicky state, and this is never a suitable state to come up with a reasonable response to such a situation. We very often see a doctor being in a hurry to respond, and they end up writing back impulsively because their thought process is not right at that time, and they will use a language that almost certainly would backfire. And never reply to a legal notice at least within the first 24 hours of its receipt. Try and recapitulate the specific case to the minutest of details. Retrieve the case files from the record section of the hospital and place all the papers in chronological order. Cross-check that the notes of all the doctors and nursing staff involved in the management of that particular case concur. Do not try to make any changes, additions, or deletions in the file because it can be considered as forgery. And make a short summary of the salient points of that particular case. Then take time to think about the allegations made. Give a thorough word-by-word reading of the document, which will give you an edge of identifying the loopholes in the documents, and you can use these to your strength in the rejoinder to the notice. Dig into past communications to find a flaw in the allegations. And then, depending upon the context or content of the notice, you will have to strategize your response, whether it is going to be a broad response or a specific one. And the intention behind this is to safeguard your own self. Now carefully revert to the notice. If this legal notice comes from a non-statutory body, do not give point-wise answers by which you open up your strategy. Give a generic, polite, and demure reply with empathy. Satisfy the ego of the patient and say that you join them in their grief. Inform the insurance company via registered post or email as soon as you receive this legal notice, and always take an acknowledgement. Speak to the colleagues and seniors before drafting the reply. Research your books and medical journals to support your answers. Retrieve the medical records of that particular patient. Seek legal help and read the allegations very carefully and give point-wise answers with clarity. Always understand that there should be perfection and precision in your answers. The documents which are required to be referred are the indoor case records, the OPD prescription papers containing the diagnosis, registration number, and the generic names of the medicine should be written in capital letters. Receipts of the payment received, discharge card copies, copies of transfer memo in case you have transferred the patient to another hospital, and record of equipment maintenance with their bills. For example, the oxygen cylinder has been filled, when has it been filled, and its bill, or when has the ultrasound machine or an MRI machine or a Boyle's apparatus being serviced. So all these things need to be taken into account and should be attached to the legal notice. Then the registers which are required to be referred to are the MTP, PCP-NDT, birth or death register, the OPD, IPD registers, medical certificates, consent forms, the OT or the labor ward, even the PAC papers, the drug inventory, when the sterilization and fumigation was done, especially sterilization or autoclaving of the instruments. So there's a particular autoclave tape which comes, which is stuck to the autoclave, and this changes color when a particular temperature is reached, and which proves that yes, these instruments were sterilized. And after that, you can stick this in the register and even a swap register. You will collect the references from the medical textbooks, Indian and foreign journals, guidelines of medical associations or the standard operating protocols, accepted medical practice. So you'll always try and take an expert opinion in this situation. So whenever there are two schools of thought or there are two routes of treatment and you choose one of them, the law is not going to ask you why you chose one particular route over the other. But you have to be careful that it should not be a rejected practice, that particular management should not be obsolete, and basically it should not be your whims and fancies. It has to be evidence-based. Then also dig into your law books, your law journals, and the internet to find out any particular case where a judgment has been given in favor of the doctor, which is a similar case to yours. and these are called as precedents. Then answer can be drafted on a simple paper or letterhead enumerating the symptoms, signs, diagnosis made, treatment given, side effects, complications, and the outcome of the treatment. In practice, never criticize your colleagues, because when you cut others, you also fall with them. So no blaming and no medical jousting. Always keep a copy of your reply. Line of defense should be decided in your mind in the first instance. Never admit anything in court which you would need to refute later. Reply to the notice needs to be very simple, factual, refuting all patient allegations and accusations of negligence. And you have to state categorically that you followed the standard operating protocols. And in case an adverse event occurred, you have to state that it was unfortunate and in no way due to the negligence of the treating doctors. The details of the defenses which you are taking in the case need not be revealed in the reply. So grounds of defense are very important. You should be able to justify every statement you have documented. Every answer should be according to the standard operating protocols and should have a reference. And both consent for treatment and refusal of treatment should be categorically documented. Now, whenever you receive a legal notice, the hospital is going to set up an inquiry committee, which is made up of a panel of doctors other than the treating physician, who will discuss this said case and they will give their opinion. And this opinion should also be submitted in the court along with the other documents. Now, can an affidavit made by colleagues on just the basis of case records when the person has not even seen the patient, can this be done? So the answer is yes. Any positive comment in favor of the accused holds convincing value. The time period defined to file an answer in the professional regulatory body is 30 days. In the consumer court also it is 30 days, but it can be stretched to 45 days. In the other courts, there's a stipulated time. And in case the documents are not submitted in the stipulated time period, then the right to a written submission is forfeited under Consumer Protection Act. Any addition or subtractions which are done in the existent medical records after receiving a legal notice hold absolutely no legal value. So never erase or use a whitener. Changes made in the existing file after receiving a legal notice is considered as cheating and fraud. Using a different pen or handwriting is also considered deceitful. Notes of other doctors who have seen the patient should be put forth without any change. And the notes of the doctors of various specialties, nursing staff, and attendants should concur. Never alter the records as it leads to loss of credibility. The documents will be handed over from wherever the legal notice had come to the patient, to the police, to the government authority, or even to the consumer court. The time period for maintenance of the IPD patient record is 3 years. MTP is 5 years from the calendar year it relates to. PCPNDT is 2 years. ART is 10 years. And after this, maintained in the central database of National Registry. Surrogacy is 25 years. But in my opinion, please do not destroy these records because a criminal case can be filed on you at any stage. And in case there is some legal proceeding which is going on till the end of all the legal proceedings. In today's date, in any obstetric case, you have to maintain the records for 21 years. The time period for providing information of records on patient request is a stipulated time period of 72 hours. And if not complied with, the government, after inquiry in the issue, can seal the center or deregister it and may even impose penalty. So failure to produce records is also considered as negligence and deficiency of services. The common defenses which are used by medical practitioners when answering, one of them is contributory negligence, whereby the doctor says to the patient that you are also negligent. So here the total compensation will not be lost by the patient, but it will be reduced, seeing the amount of negligence which is there by the patient. For example, declining meds and treatment, not following a diet, going ahead for a second opinion here and there, not coming over for the follow-up testing. Another one is the error of judgment or diagnosis or a mistake of fact, where the doctor has not been able to convey what he understands to the patient, and there is a communication gap between the two of them. Then again, as we spoke earlier, accepted practice, which is also called as the Boehm's test, where it has been said that a doctor is not guilty of negligence if he acts in accordance with a practice that is accepted as proper by a responsible body of medical men skilled in that particular art. So if a gynecologist is saying that this is an accepted practice, then that is a very good defense in our favor. But it should follow the standard operating protocols. Then another defense is that you had taken an informed consent after telling what kind of a procedure you are going to undertake, what are the benefits, what is the purpose, what are the side effects, complications, long-term hazards, what is the percentage of success, what are the alternative treatments available, and what are the adverse consequences of refusing this treatment in a language which the patient understands. Then another common defense is that it was an accident, and another one is that it was done in good faith. So when a patient comes to you in an emergency under Section 30 of Bharatiya Nyaya Sanhita, you can save yourself even when you're doing a procedure, even without consent. Very, very pertinent question. Can you change your line of defense in subsequent hearings? So the answer is no. So whenever you are drafting the answer to the notice, a lot of thought should be given to this issue in hand. The line of defense taken has to be submitted in the court of first instance. In subsequent hearings, you cannot change or add any line of defense. Now, suppose you are thoroughly dissatisfied with the judgment that has come up and you go ahead for an appeal. Now, can you change your line of defense in an appeal? Again, the answer is no. Should you try to defend yourself in court? The answer is that you may, but preferable to use a lawyer for defense, as legal language and presentation can be better expressed by an advocate along with a medico-legal expert. So you will choose your lawyer, and the lawyer should be available, should have an understanding of the subject, should be affordable, a person of integrity and trustworthy. And the lawyer should be very clear in his understanding as to what goes in favor or against his doctor-client. It is 100% mandatory to take a professional indemnity insurance before you start practice. Cost of professional indemnity is continuously rising, seeing the amount of compensations being awarded by the courts. This is when you are purchasing the insurance policy, but when you are asking for a claim, this is the situation which comes up. So ensure that you take a very, very good policy. This is when the doctor is saying that after giving the compensations and reimbursement, I've calculated my new retirement age, and that is 98 years. Settlement of dispute outside court is like a noose around your neck, or like this bull with his horns goring your back, or sitting in on the railway track thinking that the train is never going to come. So settlement of dispute outside court is considered as admission of guilt, except for situations when the negligence is evident, like mop or artery forceps or metallic clip of suction cannula which has been left in the abdomen, wrong blood transfusion, gangrene after IV transfusions leading to amputation, or an expired injection leading to death. But understand, if you are doing this in your clinic, it does not give you indemnity from further proceedings. In a number of cases, we see that when the legal notice comes, the doctor tries to negotiate with the patient in the clinic. And this, in case this case goes over to court, this will be taken as an admission of guilt. So you go ahead with a mediation, which is now available through the Consumer Protection Act, consumer courts. To summarize, acknowledge the receipt of the notice, address each claim or allegation, either admitting, denying, or explaining your position, provide relevant evidence to support your defense, clearly state your desired outcome, whether you want a settlement or you want negotiations or you want a dismissal of the complaint. Maintain a professional and respectful tone while answering the legal notice. Avail the services of a good lawyer, and timely filing of a written statement, affidavit, and all other documents as per rules is advisable. It is important to properly maintain the case history, clinical records, affidavit of all the treating doctors, X-rays, laboratory test results, which will be of immense help in supporting the doctor's claim. And expert evidence needs to be taken by a qualified and independent medical professional. And it is advisable to file an affidavit of the expert as well, along with your answer to the legal notice. Corroborative medical literature on the subject should be submitted. Relevant case laws on the subject will also be helpful. Avoid communication with the patient or their family directly. Channel all communications through your legal representative. Put up a good defense at the time of the hearing. So, law is a watchdog, not a bloodhound. And as long as the doctors do their duty with reasonable care, they will not be held liable, even if their treatment was unsuccessful. And this has been said in the Supreme Court of India by Justice Lodha and Markandeya Karju in the case of Martin D'Souza versus Muhammad Ishfaq of 2009. So this is going to be our future, where the doctor is telling the patient, my lawyer will now notify you of my diagnosis. And the patient is saying, the hospital lawyer is here, my lawyer is here. Representatives from the insurance company, the ethics committee, and the government are all here. Where's the doctor? Because the doctor has run away. This is when you pat the child, when the child is born, to make the child cry. And in our future, the child is going to say that when I was born, the doctor spanked me on my bottom. I bet I can sue him for sexual harassment. This is when everything is going hunky-dory between the patient and the doctor. But the minute the patient is dissatisfied, he sends you a legal notice. But in case you have your documents, your consent forms, and your papers in place, you can give a befitting reply to this legal notice. Wishing you all a litigation-free practice, and thank you very much for a patient hearing.
That was an excellent presentation, Dr. Arti. It's unfortunate we have not met in our medical legal arena before, but I'm sure in future, because I am now free and moving around in the country medical legally. So we sometime we'll definitely meet.
Yeah, definitely.
First of all, I'm thankful to Sneha for giving me this opportunity. And even being in America, I'm able to join because it's morning in America. And I remember having given this lecture on the same topic in AICOG when probably Dr. Prakash Pawar was chairman Medical Legal Ethical Committee. And the presentation today is entirely different from what I presented 20-25 years back maybe. But the increased cortisol levels and adrenaline levels, which a notice increases or which notice induces, are definitely will be reduced by your presentation with rich cartoons and humorous pictorials in it. Thank you, Aarti. The only one thing I would like to correct is, and you might, if I correct me also if I stand wrong, out of the court settlement you talked about is not actually out of the court settlement. It is in front of the court with the connivance or agreement of both the parties, and it's a legally binding thing. What you were talking about is probably compromise, which is done without the and that is a hanging sword on your neck. So I have to make difference between a compromise without the help of the court and settlement in front of the court or out of the court settlement. So these are two distinct entities. I think I have, if you think I stand corrected, I will accept it.
No,
But
no.
that's the situation.
I had specifically said that when the doctor tries to do it in his own clinic, because
Okay,
this
that's
does not
yes.
give you indemnity from further proceedings.
Maybe I
Can
did not
still
hear
go over
it.
to court. Yeah.
Yeah, maybe I did not hear
And
it.
because in
But
today's
otherwise,
through the consumer court, we have mediation available to us.
yes,
So
now
why
it is
should we
available in
go ahead
the
with that? We should not.
2019 amendment. It is available. Yes, yes, you are very much correct.
Yes,
So I
Ajay
think
also wants to make a comment after you finish. Girish sir.
yes, nothing is left to imagination after Dr. Aarti's presentation. I think doctors will be helped a lot. And one more addition I would like to make, Aarti, you yourself are a medical legal consultant. While drafting a legal reply, involve medical legal expert also. They can give a lot of insight into the notice as to which points are to be stressed, because the lawyers are really naive about medical subject. We have put in so many years, that is not for waste. We know so much of medical field.
Yes.
Lawyers, you can't expect them to know that much.
And I made this with the cartoons because this is such a drab topic and people are so afraid and so scared after hearing these topics that I felt that this should not be
Humorous. Yeah, you added it. Rightly so.
We normally say that you are very afraid. People feel that they should stop practicing. But like when we are on the road and we see a policeman, we start driving our vehicle very, very carefully. So it's a similar way that when we see the law is sitting on our head, we just have to become careful. We should not start getting scared that, we'll stop the practice or it's becoming difficult.
Yeah, I will add to that in spite of everything, all odds we are facing, I still insist that medical profession is the best profession.
Yes, sir. But it's a noose around our necks. Every time we come out of the surgery, we actually feel that, okay, fine, cleared. We are now clear.
It's okay, collateral damage.
Yes, Ajay, you had something to say?
Yeah, I'm so sorry. Aarti madam has cleared everything, and as Girish sir said, I was willing to add one thing in the out of court settlement. As he said, Girish sir said correctly, there is one provision which is called as the Lok Adalat. It is available at every district place. It is a legal thing to have the compromise state, and the compensation is given through the court. And once you give the compensation through the court, then you are not liable for any case against you in anywhere in the law. So that is a better option.
Yes, sir,
I think Ajay, I might correct you. After the provision in the Consumer Protection Act, I think the Lok Adalats really don't entertain medical legal cases.
No. So it is
That's
there.
what my understanding is.
No, sir. It is there. It is there because in Lok Adalat, one retired judge is there.
It's always there. Yes.
The Lok Adalat is still running in every district, and the dean appoints one person, especially the medical superintendent, because I know this because Dr. Surendra Buyar, as a medical superintendent, represents this. And as he said, the retired judge or justice handles these cases, and this is, I would say, a settlement in front of the court. That is how it is.
And the positive part of this mediation through the consumer court is that the patient cannot go and appeal against you again.
Yes,
that is same is the for Lok Adalat.
And even rapid disposal also for the cases.
Correct.
So thank you so much, Madam Aarti Tandon. I'm sure your presentation has not only enriched us, but it has also entertained us, because the moment you see the notice, as you said, you really become panic, and that is how I'm sure the presentation was very entertaining. So people are little relaxed even when the notice is served. So thank you so much, Madam. I think I could see Madam Anita Singh, who's the guest of honor today. She was busy, and she had just joined. So may I request Madam Anita Singh to have few words from her side? She was here actually, just a moment ago she was here. But it's okay, I think she has left. She was waiting, she was there for your talk.
I'm wishing you all the best for the elections.
Thank you. I need all your blessings, prayers, and support as well. Thank you so much. So we can move ahead with the third talk now. Sahiti, can we have the CVs of chairpersons?
Okay, ma'am.
Yeah. Yeah, so the third talk is by none other than Madam Jamuna Devi, and she will be speaking on MTP Act amendment. May I invite the chairperson, Dr. Alka Kuthe, who is currently the FOXI chairperson for MTP committee, and all of us know that she's LLM and PG diploma in human rights education, and she is also the IMA Maharashtra State Medicolegal chairperson for in the year 2023, and she was the national coordinator for FOXI Ethics and Medical Legal Committee, and of course I think even for AMOGS she's working in all the aspects of medical legal issues, and she's trying to help members. So welcome, Dr. Alka. And we have Dr. Shamal Seth. I hope Dr. Shamal has joined, though he was busy. He's the Vice President at present for FOXI and consultant practicing gynecologist in Kolkata, visiting specialist. So we welcome both of you, and I hand over the session to you, Dr. Alka, for introducing our speaker, Madam Jamuna Devi.
Yeah. Welcome. Yes. Thank you, Sneha, for inviting me for this wonderful webinar on medical issues, which is my actual passion since many years. And I can see Dr. Prakash Pawar, sir, Dr. Warke, who are like Brahma, Vishnu, and Mahesh, Sanjay Gupte, sir. So I pray to the God that give us always guidance of Dr. Prakash Pawar, sir, and of course, Dr. Sanjay Gupta and Dr. Dilip Warke. So I have to introduce today's speaker, Dr. Jamuna Devi. Jamuna Devi actually doesn't need any introduction. She's a good friend of me in medical field, and we had discussion on many issues so many times during Hyderabad conference and also whenever we met. But still, the issue today we are going to discuss, or rather Jamuna Devi is going to discuss, is still many new, or I can say many controversies and dilemmas in the minds of obstetricians. Whenever a patient for MTP comes to us, whether she is below 18 or whether she is above 18. If she is below 18, no doubt they have to inform to the police station. But today we are going to discuss on MTP Amendment Act, what made a difference for us and of course for the obstetrician. To introduce Dr. Jamuna Devi, she was the president of Hyderabad OBGYN Society in 2015-16. She was the joint secretary of TCOG, means Telangana Society, in 15-17. Actually, she has got many posts in Telangana and Hyderabad societies. Many positions in the past.
Alka, so, I think, thank you so much. It's thank you for that. I think all of us know each other.
Yeah.
So we'll save time.
Good human being, that is, and good friend. That is very important to introduce about Dr. Jamuna. Over to you.
Thank you. Thank you.
I'm actually from uncertainty and
yeah. Thank you, Sneha, for invitation. I think after that elaborate talk on death on table and the notice served, how to receive it and how we should go ahead with it, that was wonderful, I think. I think a lot of delegates, whoever are there, will benefit with this. So without much ado, I think we will move on to this. Although MTP Act has new amendments, but still I think we have to remember that what 4 things are very important. That is indications for termination of pregnancy and who can terminate, the place where it can be terminated, and most importantly, consent.
Jamuna Devi, can you do a slideshow? Slideshow. Please do it.
Okay, come on.
Slideshow.
Abba, now it's okay?
Yes.
Yeah, thank you. So, we when I go for inspections under PCPNDT in the state, I still see a lot of doctors they do not have consents. I don't know why so many doctors in so many fora, they keep explaining that consent is very important and it has to be taken and it is mandatory, and not taking consent itself is negligence. You are punished for that. Despite that, still I see even today, I'm telling you, I'm not surprised because most of the young doctors, they do not take the consent. I don't know with what courage they are practicing, and they end up into these litigations. So we know this, how this amendment bill was formulated in 2020, then bill passed by Lok Sabha, then Rajya Sabha, then it became an act by extraordinary gazette in 2021, March 25th. So what is this futuristic historic change? Because everything is for a comprehensive care, which is mandated by the law. So what has changed? Law has changed in 2021, but rules have changed in September 2021. As we all know, though it is a national amendment, but the state has its own rules and regulations they formulate. And the most important thing what we have to understand is today mortality, morbidity is increasing because of abortions. And they say that 80% of maternal deaths per year due to abortions. That means it's third leading cause of MMR. And nearly 2 out of 3 of the abortion performed are deemed to be unsafe. And nearly half of pregnancies related deaths are in women who are under 24 years and where their full participation is lost in the society. So now I'm not going to talk about the previous laws, but I'm just going to tell what are the previous act had and what is the new changes we had. And it is beneficial for doctors as well as the woman who is pregnant. So previously we had provider for MTP up to 12 weeks where only one RMP is necessary. And for 12 to 20, there are 2 RMPs are necessary. And beyond 20, we were not allowed to do any terminations. But the new amendment, what it says is that up to 20 weeks, now only one RMP is required for termination. And between 20 and 24, when there is termination, then we require 2 RMPs. And this is only to facilitate, especially in public sectors, like in PHCs, where services provision till 20 weeks may be provided and patients may take the benefit of, women can take the benefit of these provisions. Then previously MTP is permissible, as I told you, up to 20 and not beyond 20. And always it is immediately necessary to save the life of the pregnant women. That was the reason why the termination was done. But now one is upper gestation limit is enhanced from 20 to 24 for special vulnerable categories. These 2 things are very important for all the delegates to remember. You can't terminate any women walking to you and asking for termination after 20 up to 24 weeks. They should fall in the special vulnerable categories. Then another addition was that birth defects which are not compatible with life, these can be terminated anytime, but with the consensus of medical board. So these 2 things have been amended in this new law. So this increase of access for vulnerable women is to safe and legal abortion services. And these are included like victims of rape, minors and others. I will tell you what are those categories in the later slides. Then the Act had provision for termination up to 20 weeks, but upper gestation, as we said, that substantial fetal abnormalities which are diagnosed by the medical board. This we have said, because most of the time, now, of course, our fetal medicine specialists, they can detect the fetal anomalies by 20 weeks. But in a few years ago, they never be able to detect this medical fetal abnormalities. They would detect only beyond 20 weeks. And that is the time termination was so difficult, and they had to run to the courts for the permission and all that. So now this medical board, if it is diagnosed, the medical board will help the women to go for a termination. Then condition of failure of contraceptive was applicable only for the married women and her husband. But now the change is that failure of contraceptive is extended not only to the married women or her husband, but now they say that women and her partner. So these two, this is a good change, because we see a lot of living in relationships and all those things. So there they do not have to pose for any difficulties for terminations. Then MTP Regulation 2003 mentioned that information should not be disclosed except under authority of law. But in addition to that, the new amendment says that name and other particulars of a woman whose pregnancy was terminated shall not be revealed except to a person authorized by any law for the time being in force. So this confidentiality has to be maintained. This is very, very important. And now we say that we don't write the names, but we write the numbers, serial number in the registers where we maintain the MTP registers. Then what are these new rules? One is special or vulnerable category of women who are eligible for extended gestational termination of pregnancy from 20 to 24 weeks. Then what are the norms of this RMP, that is registered medical practitioner, whose opinion is required for termination of pregnancy at different gestational age? Then what are the powers and functions of the medical boards, which are formed for each state and mandated to provide timely and evidence-based decisions so that termination can be done safely and within the time? So these are the categories. I want every delegate to remember these 7 categories, because when you're doing termination between 20 and 24 weeks, the termination category of the woman should fall into one of these. Because even today, there are normal pregnancies which are terminated beyond 20 weeks, and they do not fall on this. And remember, mind you, if the patient comes to know about that such a law is there, they themselves will file a case against you, and you cannot get away from that. And this happened recently in one of our districts. And I feel very sorry about it, because the doctor has done a termination and not taken the consent of that woman. So this case has gone to the collectorate, DMHO, everywhere the case is gone, and they have seized the case sheet, and she cannot do anything. So please take the consent immediately whenever you or train your staff how to take the consent. And this is very, very important, because most of the people who have very busy outpatient, they do not have time to take the consent and all that. But at least when you're doing the procedure, check for a minute whether the consent is there or not, because that will save your time and other life from litigations. So these are the 7 categories, that is sexual assault, survivor, rape or incest, or pregnancy which happened in humanitarian settings like disaster. That emergency situation should be declared by the government, or marital status is changed, whether widowed or divorced, and physical disabilities. And these physical disabilities should be under the Disability Act. You cannot say that any disability you can do it. No, that should come under this Disability Act. Then mentally ill women, including mental retardation, And this also, the women has to be categorically come under that Mental Retardation Act. And minus, of course, we all know POXO is very, very strong, and we have to be very careful whenever we are dealing with this minus. And of course, fetal malformations, which has substantial risk and incompatible with life, that can be terminated anytime, as we have understood with this new amendment. So now coming to now earlier medical abortion was not included in this, but now medical abortion is included in this, and you have to maintain all the consent forms and your registers as you do for MTP. So up to 9 weeks, whenever there is medical management, then we have 5 categories. One, that any RMP with 10 cases under supervision of another RMP, and the hospital should be an established one. Mostly it should be a government hospital. Then second one is the RMP should have assisted 25 cases, and at least 5 they should have been done independently. And third, of course, postgraduate degree or diploma. And fourth one is 6 months of house surgency in obstetric and gynecology, not as a routine, only 3 months and then you are allowed. No. Then fifth one is 1 year in the practice of obstetric and gynecology, because most of the doctors, they do 1 year senior house surgency in obstetric and gynecology department. Then we have up to 12 weeks. We have now 4 categories. The one with 25 cases assistance and 5 independently done. Then second one is postgraduate or diploma in obstetrics and gynecology. And third one is 6 months they should have done in obstetric and gynecology as house surgency. And the fourth is 1 year in the practice of obstetrics and gynecology as a senior house surgeon or the other. Then coming to 12 to 20 weeks. Now they have reduced to only 3. So one is a postgraduate degree or diploma in obstetrics and gynecology. Then second is 6 months of house surgency in obstetric and gynecology. And third is 1 year in the practice of obstetric and gynecology. Now up to 20 weeks, 12 to 20 weeks, only one doctor is needed for termination. So there were earlier, like previously, there were required 2 doctors, but now it's only 1. But now when we come to 20 to 24, first thing is the women should come under those 7 categories. Second, there is opinion of 2 RMPs. So whenever you are terminating a woman between 20 and 24, you have to see whether she's falling into that 7 category group. And second thing is you have to take an opinion of your another RMP. And I suggest that the day you do the termination, that day itself you should take the signatures, because most of the time the doctors who are terminating between 20 and 24 weeks, they do not take the signature of the second RMP on the same day. We have seen where there were cases where the second doctor's signature was not there, and the women went to the court filing a case against the doctor who has terminated. So please be careful whenever you are terminating between 20 and 24 weeks. Then the last one is beyond 24 weeks, postgraduate and 1 year in the practice of obstetric and gynecology. But here you can terminate only after taking the opinion of the medical board. This is a mandatory one. And once you take the opinion of the medical board, they will either reject or give the permission to termination, depending upon the case. So who is this medical board? This constitutes by a gynecologist, a pediatrician, radiologist, or sonologist. Now, what are their powers? So they are allowed or deny termination of pregnancy beyond 24 weeks of gestation after they consider and ensure that the procedure would be safe for the woman at the gestation age and the fetal malformation has a substantial risk and being incompatible with life, or if the child, when born, would suffer from such physical or mental abnormalities, seriously handicapped. So that has to be taken into consideration. And if they are not able to take any decision when the report has come to them, the medical record has come to them, then they can take a co-opt specialist. Like if there is any cardiac malformation, they will take advice of a cardiologist and then decide whether to go for termination or reject termination. So they examine the woman and her reports who approach medical board for the termination. Then they have to provide opinion in Form D with regard to the termination of pregnancy or rejection of request for termination. And that has to be done within 3 days of receiving the request. This is something very beneficial, and because not much time is wasted. And third one is to ensure the termination procedure, the medical board carried out with all safety precautions along with appropriate counseling, and the termination should happen within 5 days of the receipt of the request for termination of pregnancy, and it should be done in a safe and safe environment. Mostly it is better to send to the government hospitals. Then what are the common records which has to be maintained, or the documentation? Like Form C, we all know, consent form. Then Form 1 is RMP opinion, Form 2 monthly reporting form, and Form 3 admission register for case records. When we go for inspection, most of these monthly reporting registers are incomplete and consent forms are not taken. And all these incomplete will invite issues with you from the appropriate authorities. Now, the recent new one is Form D. This is the report of medical board for termination of pregnancy beyond 24 weeks. So this Form D is important when the termination is happening beyond 24 weeks. Then Form E is opinion form of registered medical practitioners. So that this is for the gestational age between 20 and 24 weeks, where 2 registered medical practitioners have to sign. So this is the dedicated form which should be used. So registration documentation, as already said, 5 years and 2 years preservation is very, very important. And I think Dr. Aarti has told very nicely all the details of this documentation. And thank you for your time. I think this is what I thought I will tell. And I will share one case recently which happened. As one of the doctors, one lady has approached to the doctor. According to the ultrasound, it was 21 weeks. And she was very anemic. Blood was transfused, 2-3 bottles, and then termination was done. And second, the doctor's opinion was not taken. And the consent was not taken. And I don't know how they came to know. A third party has filed a case against the doctor. And now the patient and her husband, the woman and the husband, is ready to give the recording and give their writing complaints. And unfortunately, the doctor is out of station, and DMHO has come and seized the case sheet from the hospital, and the case sheet is incomplete. So this is the situation even now. I don't know. So much we talk about the consent, and we tell consent, consent, consent. So many times we tell. I don't know why they don't take consent.
Yeah. It's true. Exactly what you have said is correct, Dr. Jamuna, because in spite of so many legal issues against the obstetricians, and in spite of so much amendments in the law, but people hardly use the knowledge, because many times they just take it lightly. It's a MTP, but MTP is a blind procedure, and because the place is not recognized, because the person is not RMP, because the indications are not as prescribed in or given in MTP Act, it is punished, and punish is imprisonment and fine. And because there are certain deficiencies in documentation, because there is a breach in privacy, all these things are very important. But many times what you have said correctly, sometimes they just take it lightly. It's a MTP of only 7 weeks. Whatever gestational weeks are there, but you have to complete the record and always follow the laws of the land. When you violate the law, of course, the punishment will be there. So I wonderfully explained everything about the Amendment Act, and I think it was a very nice revision. At the same time, some cautious words given by you. Abundant caution, we always say abundant caution. So always protect yourself while doing good for the patient. So once again, it was a elaborate lecture. Thank you very much. And again, best wishes to Dr. Sneha.
Yes. Thank you, Alka, and we welcome Dr. Shamal Seth. Of course, all of you know, a very apt person to chair this session, past committee chairperson for MTP. So, can we have your comments, please, Dr. Shamal?
Sorry for joining little late, but I heard the most of the topic I heard actually. Now about the Amendment Act, you have discussed everything. But one thing I always believe that these statutes, these acts are made always against the doctors. You think of anything. Now, when we are making MTP as an act for the liberalization, for the help of the women's health, okay, what should be so fast about this confidentiality issue? Government has not taken any steps against over-the-counter sales of the medical preparations.
Yes.
But there is a provision for the doctors. The doctors should not leak the confidentiality. Now, on one side you are saying this is legal. Legal. If you follow the provisions, if you follow these terms and conditions, it is legal. Then why confidentiality is illegal? And think about, if somebody does not maintain this confidentiality issue in a good way to do a termination of pregnancy to help that particular girl or woman, a doctor has to be behind the bar for 1 year. It's not a matter of joke. I don't know what kind of statute, what should I say? Now, the statute making or law making authorities, they do not think about the life of the doctors, unfortunately. So only this thing is dangerous, and our fortune is that the patients are not aware of this provision. Most of us, it's very difficult to maintain confidentiality, you know. And if you want to maintain all these things, making recordings, sending records or documents to the CMOH, everything, now just imagine what the cost can go up. If I am to maintain all these things, it's my headache that I will fill up those forms, I'll have to send to the CMOH, I'll have to maintain confidentiality, so I'll have to do so much of works. Then in private sector, my fees is going to be so high. So I can't understand what the government wants actually. So this is the only thing we should be very careful. Acts are acts. Ignorance of law is no excuse. We need to follow, but I still believe if people think that MTP Amendment Act is very helpful for the doctors, I beg to differ. It's not at all. It may be beneficial for the patients, but not for us. That is the only comment I can make. Thank you very much, madam.
I don't know, it is beneficial because now many things are very clear now when we are doing an MTP.
There are some gray areas.
But
still there are many gray areas. If you terminate the pregnancy even beyond 24 weeks, say for any complications, any malformations, and if the baby is born alive, what one is going to do with the baby, that is not clearly explained anywhere. Now, there is a provision that yes, if you want to deliver, then you kill the baby by whichever way you can. Now, killing is not approved by law as of now in clear words. So, who is going to handle the baby after it is born alive? Government, the patient parties, or the hospital or doctor himself? Nowhere explained. So, this is a gray area. So these things are not explained well. There are still few gray areas, and we believe there will be another amendment in coming few years only.
Because law is dynamic, it's not just static because it keeps changing. Earlier it was different, now it is different, and probably in future it will be different. But now socially also the changes in the lives of the people also is there, because there is so much of empowerment and so much of the money and freedom, everything is there now. That's the reason why they said that it's not just a married woman and a husband. They said a woman and a male partner. Yeah, because we see a lot of change in the society. So those things are there. And
That's
now,
absolutely fine.
yeah, and social media has impacted the girls and boys and men and women so badly, and we do come across these unwanted pregnancies. And if we don't do it, they go for unsafe abortions, and that way we are going to increase our morbidity and mortality. So at least when they are legalized and they know that they can go to a doctor and get it done, at least there is safety, and we are trying to reduce that morbidity and mortality. I think these are the benefits from these laws also. But at the same time, yes, medical abortion is, on the counter sales are there, which the government is not able to curtail, and people take left and right without the prescription, and the pharmacy fellow also gives, and they come with problems and all those things. That also is there. I don't say that, but at least to some extent, we are trying to bring down.
I think whenever we should, whatever positive change is there, we should accept it positively. Something has been made, otherwise IPC sections were
This is
there.
not to accept
Many
positively,
illegal
madam.
abortions, septic
This is not
abortions
to accept
cases,
positively, madam.
increasing maternal mortality, morbidity. What are these problems?
First, we need,
Something is there.
madam, I beg to differ with you. This is no positivity or negativity. First, we need to survive safely in the profession.
We'll have debate afterwards.
Sir,
we need to be safe first. Only then we can execute our services to the womenhood.
Yes.
Then only we can serve the women. Now, if
Yeah.
now you are all aware that people are doing MTP in this way or that way, not maintaining all the formalities.
Yes.
So they are just asking the patient to have this misoprostol tablet or whatever, this form or that form, in a loose paper sheet. Patients are applying. Now the patient is turning out to be a case of incomplete abortion and now completing the procedure by DNA. So exact data is also we are not getting the exact MTP figures. So whom we are going to help by this?
I do agree with Dr. Tamal on these 2 points.
Our legislatures are never considering the safety of the doctors. They do not understand the quality of life the doctors have to go through by following all these things. Now, we are not clerks. We are not clerks.
Yeah, next topic for webinar.
You need to have an assistant to maintain all these records. So your cost is going to be high. If you want to give a good service to the patient, cost is going to be high.
Everybody is not like you, Shamal. Now, if you come across the people whom we are thinking, because I go for inspection, and if I see the case sheets and forms and all that, it's so pathetic, I'm telling you. It's so pathetic.
Madam,
they don't complete the forms, register, nothing is there. And I'm telling you, even now, female feticide is on a rise. And that is how...
I still believe if I am given the opportunity, I will object to this, to maintaining all these records, etc., etc. This is not my headache. This should not be. This should not be my headache to send the reports to the CMIs. Why should I? I have become a doctor to give service to the patient, to give treatment to the patients. Why should I do all these things? Why? What for? Even the CMOHs are least bothered how much reports we are sending. Many of them do not know what is the MTP consent forms are.
Yes.
But the government has made these provisions. This is absolutely what I say, absolutely hopeless and unnecessary things. Unnecessary burdens being put on the gynecologist or doctors.
I think Shamal MC Patel sir president हो गए तो कुछ करते हैं ये सब के लिए.
But वही है कि आपको law तो मानना पड़ेगा. Law तो आपको मानना पड़ेगा.
So we look forward for him to make some change.
Should I enter in this?
Yes, sir. Yes.
Good evening,
so one by
sir.
one. Yes, Yamal.
Good evening.
Yes, good evening. Point of worry when fetus come alive after 24 weeks of termination of pregnancy. There are, of course, gray area that fetus may come alive. Who will take custody of that very baby? Patient party. Can we shift that baby in ICU? I mean NICU? Of course we can. But in government hospital, there is no problem. But in private sector, who will pay for NICU care is one more area. So one more area, can we inform police in this situation? So all this gray area, but word of caution as on today, till some amendments come, at the time of taking consent, we should clear all these things. That baby may come alive and you will take custody of baby, or baby will be shifted to NICU and you will pay for that. So if we have taken consent in that way, then we could be safe. And in spite of consent given, patient or patient party doesn't follow, then we can inform police also in this situation. But it becomes a one more headache as far as this part is concerned. Second point was concern which stressed by Dr. Jamuna. So without taking consent to terminate pregnancy is a crime. And under section 3 subsection A MTP Act, it is very specifically mentioned that if you have terminated pregnancy in accordance with provision of MTP Act, then only you are out of purview of old IPC section 312 to 316. And in those two sections, 312 and in 313, so termination of pregnancy without consent, and there is a provision of imprisonment for 10 years, and one cannot afford that. So if you are not taking consent, and if you have terminated pregnancy, and if it is proved, then you may be triable under section 313 IPC, and it will be a very difficult one. Not only to take consent, but consent to be taken in prescribed form, that is form C. Because any other form you have taken consent is not valid as far as provision of MTP Act is concerned. So consent should be in form C. But again, form C is not informed consent, because it is a very simple form. In my next talk, I will stress upon, but it is simple. I give my consent to terminate my pregnancy. That way it is written. So it is not informed consent. So you will have to go with two consent. One in form C, which is mandatory by law, and one informed consent as we take in any other case. So in that informed consent, we will explain everything, whether we are terminating pregnancy by medical method or by surgical method. That way we have to go with. And for that, consent is available on Foxy website with uniform consent. In those 30 consent, which we have prepared, Dr. Dilip Palke, he left, Dr. Nikhil Datar and myself. So in those consent, to terminate pregnancy by medical method and by surgical method, two separate consents are available. You can download and you can use in your day-to-day practice. As far as one more point where discussion, confidentiality of patient. If patient comes alone and whatever you discuss with patient, then confidentiality maintains between yourself and patient. If patient breaches that confidentiality by her own, doctor is not at all responsible, I would say. If patient comes with her husband or one relative or any other friend or so, then it is implied that she is ready to share this information to person whom she has brought. So we have to explain that should we discuss in presence of him or her? If she is ready, then whatever we discuss, we are not disclosing confidentiality, because patient is mentally prepared. But if we give any information of that very patient who has undergone MTP to anybody, then it becomes a breach of confidentiality, and provision is 1 year of imprisonment. Previously, it was not there. Previously, it was simple fine, but now it is imprisonment or fine or both. So we should be careful.
Yes, sir, one more point. As we were discussing, termination beyond 24 weeks, we will need the opinion of the medical board also. And the termination, as we were discussing about the custody of the baby if it is alive. But similarly, we have the provision of, intracardiac injection of KCL and all these facilities. When you, you are advised to do this termination in medical college.
Yes. Sneha, again, there is gray area. Because in law it is not mentioned that in more than 24 weeks you can go with ACL injection or so intracardiac, and then you turn. In foreign country it is there. If pregnancy is more than 24 weeks, first they will have to go for KCL and then they will terminate pregnancy. But in
Exactly.
India,
So is it not killing that baby?
No,
What we were discussing.
yes. So it is not clear. But for that, all these questions just we raise. Who will take custody? Police can be informed or not. If patient is shifted in NICU, you will bear the cost. And can we consider female feticide? Feticide before termination of pregnancy. So all these area needs to be amended with further amendment in MTP. And for that, here comes role of FOXI, IMA, and other association also. And for that, just mentioned by Jamuna Devi, you will have to vote Dr. MC Patel next year in 26 for president's election, and then it will be taken care on part of FOXI. But this year for Sneha, we have to work because she is a very deserving person, hardworking. I have seen her working since years together. She was with me in my Happy Learning series also. So I have seen her working very closely, and she is very deserving candidate. So I appeal on behalf of Sneha to vote and canvass for her. She should be there as a Vice President, FOXI West Zone this time.
Thank you, sir. Thank you so much. Thank you.
Once again, Jamuna,
We
wonderful.
just go ahead with the next session. Yes. And maybe introduce our chairpersons, Sahiti. So I invite Dr. Girish Mane and Dr. Meenakshi Deshpande. Yeah. So Dr. Meenakshi Deshpande is a very dear friend. She's my batchmate from Vijay Medical College, Pune. And of course, all of you know that she is very active in IMA as well. She was the past secretary of POGS, Pune Obsgynae Society, and she's the past president of IMA Pune, member of district SJ Organ Donation Committee, chairperson of IMA Pune Medical Legal and AMS subcommittee, chairman of IMA Maharashtra State Organ Donation Committee, and she's got various accolades to her credit. We're very happy to have you, Dr. Meenakshi. Welcome to this program as chairperson.
And thank you, Sneha.
Yes, welcome, Meenakshi. We have our second chairperson, my dear friend, my younger brother, Dr. Girish Mane, who is from my same society. And yes, we have been there as a chairperson of FOXI together. And yes, we are growing together. So we welcome you, Dr. Girish. Girish was the FOXI for Adolescent Health Committee, FOXI, and he is at present the state coordinator for AMOX, and he has many awards and accolades to his credit, including the Best Committee Award from FOXI, and also the recipient of Dr. Sadhana Desai Award in 2017, recipient of Duru Shaha Youth Trophy, and so many accolades to his credit. We welcome you, Girish, and I hand over the question to both of you. Over to you.
Thank you so much, madam, for this wonderful opportunity. I will keep my video closed because right now I am a patient of high-grade fever and my CRP itself is 110. But I am here just to, actually I wasn't willing to, miss this opportunity, and that's why I'm here. So let me take an opportunity to introduce Dr. MC Patel, sir. Actually, sir doesn't need any introduction. He was vice president of FOXI in 2016. He's consultant obstetrician and medical legal counselor, organizing secretary of AICOG 2017, chairperson of Ethics and Medical Legal Committee FOXI 2011 and 13. There are many things to tell about Patel, sir, but I will say a few words about today's this topic. Friends, the best medical treatment is very much important to save the patient. But nowadays, we are also vulnerable to get harmed through our medical practice. And there are few things which can save the doctors. For example, the proper doctor. No, of course, your best treatment, your skill in your medical practice is very much important to save not only to your patient, but yourself also. as well your proper documentation is very important, and probably the consent is the most important documentation, one of the most important documentation which is very important in the court of law. Actually, many times the consents are taken by many doctors or their subordinates, but most of the time it is seen that they are not following the proper rules, and these consent are of no use at all in the practice. For example, many times the consent are pre-printed, the consents are in the language of doctor, which may not be understandable to the patient or to the relatives, and the objection can be taken. So this topic is very important if you are practicing doctor, and today we are having Dr. MC Patel sir with us, who have prepared the standard consents which is published on the Foxy website. So sir, we are eager to know about the consent from you. Over to you, sir.
Thank you. Any comments from Meenakshi, or should I go to topic?
Yes, sir. Thank you very much. And actually, this was a very coveted session for you, because I also wanted to hear your talk on the consents. Consent is a very important document which is very much neglected by day-to-day practice by the doctors. They are taking blanket consent many times, and still our ideas of taking proper consent has not percolated to the nearby, remote areas. Maybe in some metro cities where they are listening to our lectures, those doctors are doing it really well. But many doctors, whomever I see the papers, when we come across some medical legal papers, that time we see that the consent form is not up to the mark, or whatever has to be taken in the consent is not written only over there. So I think Madam Sir Sneha also has a very chosen this topic very well, and especially the speaker also for this. So Patel sir, we are waiting for your talk on consent.
Yes. Thank you, Meenakshi. And one good thing, Sneha, you have invited all the people who are already in medical legal field.
Yes, sir.
And I was lucky that almost all, I had privilege to work with all of them when I was committee chair. Previously, Dr. Prakash Pawar was the committee chair, then Dilip Walke, and then I took over. And all the people who are present today as faculty had privilege to work with me, or I had privilege rather to work with them. So coming to the topic, greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. Warm welcome all the delegates, and wishing you a litigation-free practice. At the outset, I would like to thank organizers and Dr. Sneha Piyar in particular for organizing this such a important webinar today and inviting me to share my views about this subject. And again, I will thank everybody who stood with me last year during my election campaign of Foxy presidency. Though I lost, but I believe in this. This is written by Shraddhay Atal Bihari Vajpayee, and I had privilege to work under him. क्या हार में क्या जीत में किंचित नहीं भयभीत में कर्तव्य के पथ पर जो भी मिला ये भी सही वो भी सही. So thank you all. Loss is not the end, but a new beginning, and journey to serve Foxy continued with renewed patience, and my commitment still there. Wherever you are, I will be there. Promise to reach unreached. And again, I will put my candidature next year in 26 for President Foxy. Usually, I start any of my talk with this question. Is it worth discussing? Yes. And if it is yes, then why? Because medical litigations are increasing in number constantly and steadily, and we gynecologists, unluckily, rank first as far as litigations are concerned. If you go with statistic from court, whichever court, whether it is CPA, whether it is civil court, whether it is criminal court, we gynecologists, as far as medical litigations are concerned, we are in driving seat. And ignorance of law is never an excuse, because as soon as any law, any act, any ordinance passes in government gazette, it is presumed by law that each and every citizen of India knows that law. So ignorance of law can never be an excuse. And as far as we will have to understand two words. One word is agreement. Every promise and promises forming the consideration for each other is agreement. Say, for example, if I invite Girish to go for a movie and Girish agree, then it becomes an agreement. But for any reason, if I decline to go, then I am not at all liable for any problem because it is agreement. But when agreement is enforceable by law, then it becomes a contract. As soon as any patient comes to your clinic and once you accept her to treat, it becomes a contract or implied contract between patient and yourself. You are offering your expert services, patient pays for that or patient promises to pay for that. So when agreement is enforceable by law, it becomes a contract, and when it is contract, then there should be proper counseling and proper consent. So if we go by Indian Contract Act section 13, when two or more persons agree upon the same thing in same sense is a consent. So two or more than two persons agree for same thing in the same sense without any dispute, then it becomes a contract. And as far as our contract in our medical field is concerned, it is voluntary agreement or compliance or permission without compulsion, where legal validity of it depends upon it being given after understanding clearly what it is for and risk involved. So all these points are taken into consideration well, that patient should have understanding why she is giving consent, for what she is giving consent, which are the risks involved. So everything should be there in that very consent. And this is very famous case, Samira Kohli versus Prabha Manchanda, which was decided in Supreme Court in 2008. And in that very case, it was very specifically mentioned, it is more than just sign here. So consent paper is not paper where patient or patient party has to sign, just sign here. It is more than that. So I do not go into detail of facts of that very case of Samira Kohli, but it is very important that during deciding this case in Supreme Court, concept of consent in Indian context was discussed and decided at length, and Supreme Court came up with guideline what should be the ideal consent in Indian context and which are the criteria for consent to be valid. It was decided and discussed in that very case. So as far as consent in India is concerned, it should be lawful. Consent given for any unlawful activity is not valid. Say for example, patient is suffering from terminal stage of cancer and he is suffering lots of pain, and if he requests or if she give consent to give poison or to give any injection, is not allowed, because euthanasia is not allowed, it is not lawful. So any consent given for unlawful activity is not valid, because euthanasia is not permitted in India as on today. One more criteria for any consent to be valid, that is capacity or competence. Who can give consent? Any adult patient who is mentally sound can give consent. Nobody else can give consent on her behalf when she is major, when she is adult, and when she is mentally sound. One more area, when patient is minor, then guardian will give consent. When patient is mentally challenged, then guardian will consent. Minor or mentally challenged patient cannot give consent. Even if they have given consent, it is not valid consent in eye of law. Can minor girl give consent for examination? Say for example, if it is victim of sexual assault and she has been brought to you for examination and to do needful, then can she give consent for examination? Yes. If she is more than 12 years, then she can give consent. Of course, she is minor, but in eye of law, she is considered matured minor. So if she is more than 12 years, she can give consent for examination in that very situation. But one more area, can she give consent for surgery or procedure if at all it is required? Say for example, if she is bleeding and some stitches are required, if there is something and you have to remove that. So in this situation, if at all you have to go for any anesthesia. Can she give consent? No, she cannot give consent for that. In this situation, consent will be given by guardian. Can visually challenge give consent? Of course, yes. If she can hear you properly, you can explain everything and she can give consent. But in this situation, guardian or some witness should be there and they will sign the document that before us everything was explained to her and she has given consent. One more area. Can deaf and dumb give consent? Of course, yes. If she can read, you can give all the papers to her, and if she can go through and she is convinced, she has understood, then she can give consent in this situation. But again, I would prefer to have signature as a witness from guardian or her relative. It becomes a good document. One more area. If it is an emergency, no consent is required. But again, burden of proof will be on your shoulder to prove that it was dial emergency and whatever you did was in good faith of patient, then no consent is required. But burden of proof your on shoulder. So you will have proper documentation in which condition you took decision to proceed further without consent is very much must. Consent should be voluntary, it should be free, it should be signed by patient or guardian as per the case may be, and others are witnesses only. So if patient is major, if patient is mentally sound, nobody else can give consent on her behalf. Consent should be informed one. Are your patient properly informed? Is one more criteria for any consent to be valid. Patient should have knowledge about nature of treatment with all its benefits and all its side effects. No fraud, no coercion, no false promise as far as any promise at the time of taking consent is consent. All the available alternatives should be explained to the patient. Patient is free to choose any alternative. Say, for example, if it is a case of ectopic pregnancy, and if you have available two options, if you can go medical method or if you can go surgical method, and in surgical method, endoscopy, open surgery, conservative surgery, removal of tube, all the alternative you have to explain to the patient, and patient is free to take any option. But at the same time, you may explain patient which option is best available for her, and if patient convinced, then it's fine. Otherwise, you have to follow instruction of patient only. You are also under obligation to explain about success rate about procedure or surgery which you are going to go for in your clinic, in your city, in your state, and in country. So it is expected by law, expected by from court, from us. So as far as our uniform consent is concerned, just I mentioned prior, it is available on Foxy website with 3 medico-legal experts, Dr. Nikhil Datar from Mumbai, Dr. Dilip Palke from Pune, and myself, Dr. MC Patel from Ahmedabad. We have prepared almost 30 different consent, and it is available on Foxy website. It is available in English, in Kannada, in Marathi. Gujarati version is ready. Final touch is being given, and it will be soon available. Hindi version is also on, and it will be available in Hindi also. I request other societies from other languages to come forward and translate all those consent in their respective language. It will be much useful to our professional colleague. We have prepared those consent with 2 headings as per guideline from Supreme Court in Samira Kohli case. Part 1 is information about surgery or procedure. Say, for example, name of procedure, cesarean section. So meaning, what is the meaning of cesarean section? We have given in a very simple language to cut open abdomen, to cut open uterus to deliver baby. That way we have prepared. Purpose or indication, we have given all the indication of respective surgery, whether it is cesarean section, whether it is hysterectomy, and in hysterectomy also abdominal, vaginal, endoscopy. We have prepared all those consent as far as indications are concerned. Description of procedure, how cesarean section is done. how hysterectomy is done, how wash tightening is done. We have prepared all the consent separately like that. Benefit of procedure. If cesarean section is done, what is the benefit to the patient? Alternative. If patient is not willing to go for cesarean section, are other alternatives available? We have mentioned those also. Consequences of refusal of procedure. If patient is not willing to give consent, then which are the consequences of refusal? We have mentioned that also. Outline substantial risk related to anesthesia, possibility of excessive bleeding, blood accumulation, possibility of infection, possibility of injury to surrounding structure. Every individual has a different way to cope up. We have mentioned that also. Very rare condition like allergic reaction to drug, we have mentioned. And when we are dealing with obstetric condition, then neonatal morbidity, in few of the cases neonatal morbidity also we have mentioned. That is outcome of baby, possibility of NICU care, we have to explain. Part 2 is undertaking. So whatever we have explained in part 1, patient will go in undertaking that whatever explained to us in part 1, we have understood and we have given consent. We have mentioned this also, which is reflected in red color. I understand that during course of surgery, doctor may find other unanticipated unhealthy condition that may need specific action, procedures, surgery and anesthesia. If doctor feels that it will be beneficial to treat such condition while performing proposed surgery, and if I am not in mental or physical capacity to give consent, doctor may take necessary decision after discussing with Mr. Mrs. So-and-so. I authorize the above mentioned person to give proxy consent on my behalf. If patient has given consent like this, in given situation, you can discuss with relative, and if relative are willing, that you can very well proceed with surgery further. We have mentioned like this also. In order to save life, it may even be necessary 2 additional surgery or procedure and prolonged anesthesia, which are beyond the scope of consent given by me. I authorize doctor to take such decision if need be. If patient has given consent like this, then no need to discuss with anybody. You can very well proceed further accordingly. But again, I have mentioned already, burden of proof will be on your shoulder. Why you prefer to go beyond the scope of consent given, and by proper documentation, you will prove it. And at the end, you will go with signature or thumb impression, whichever the case may be, and 2 witnesses, 1 witness in favor of patient, 1 witness in favor of hospital, and signature of doctor is also very much must. Why? Because just I mentioned, when you decide to treat patient, it becomes a contract. And under Indian Contract Act, unless all the party involved in the contract signs the document is not complete. So signature of doctor in consent paper is also very much must. One more area. Does Supreme Court expect us to talk about all possible complications at the time of counseling and taking consent? So Supreme Court has very specifically mentioned we are under obligation to anticipate certain complications or requirements depending upon the condition of the patient. Say, for example, if it is a case of central placenta previa, court expect from us, law expect from us to anticipate that she may end up into PPH, she may require blood transfusion, she may require obstetric hysterectomy also. So we should be prepared to deal with the situation, and we should have all the arrangement to deal with the situation. It is anticipation or foreseeability, and it is expected from court, from us. But at the same time, court has specified no need to explain remote or theoretical risk involved, which may frighten or confuse patient and result in refusal of consent for necessary treatment. So no explanation about remote or theoretical risk. Can we allow attendee during surgery? Can we record that very surgery? And can we display in conference, in webinar, or in teaching institution or so. For all this, prior consent is very much must. And if at all you are going to display anywhere, then personal identity of patient should not be revealed. We should be very clear about the things. Separate consent for anesthesia. It is very much required, and we have to explain about nature, benefits, purpose, effects, alternatives, and substantial risk involved in anesthesia. And anesthesiologist is the best person to deal with. So all this should be explained to the patient by anesthetist, and consent should be taken separately for anesthesia. One more area, separate consent for blood transfusion. If you have planned blood transfusion during surgery or just after surgery, then again separate consent for the blood transfusion is also must. And at the same time, we will have to explain purpose, effects, alternative, and substantial risk involved in blood transfusion to the patient. Because in one of the cases, Supreme Court has very specific, National Commission has very specifically mentioned that surgery involves risk and blood transfusion involves additional risk. So separate consent for blood transfusion is very much must. One more area, refusal of treatment. Patient may refuse treatment. Patient may refuse to sign the document of consent. So in this situation, Supreme Court expect from us need to explain risk of refusal of treatment. But at the same time, Supreme Court has specifically mentioned no need to explain remote or theoretical risk of refusal of treatment, which may persuade a patient to go for a fanciful or unnecessary treatment. So we have to maintain the balance as far as explanation of probable complications or risk involved in that very procedure or surgery. One more area, common consent. Can we go in with common consent for diagnostic and operative procedure together? Say, for example, diagnostic laparoscopy and ovarian drilling. Of course, you can go with common consent. In the same way, particular surgical procedure and additional or further procedure. Say, for example, cesarean section with myomectomy, cesarean section with tubal ligation, of hysterectomy with bilateral salpingectomy, bilateral salpingo-oophorectomy. So you can go with common consent for particular surgery and additional surgery together. Consent given for specific treatment cannot do other procedure unless it is life-saving. An argument that it was beneficial, would save time, would save pain and suffering in future doesn't stand in court of law. Say, for example, during cesarean section, if you find next pregnancy dangerous to the patient, but even then, if patient has not given consent for tubal sterilization, you cannot go for tubal sterilization. And this type of argument that it was beneficial for the patient in future doesn't stand in court of law. And let us see this case. It was case of primary infertility for diagnostic laparoscopy. Consent was given for diagnostic laparoscopy only, but on table after anesthesia during diagnostic laparoscopy, our doctor friend went with ovarian drilling and salpingectomy, for which consent was not given. Case was decided against doctor and compensation of rupees 25,000 with cost 2,000 was awarded in favor of patient. So it was for ovarian drilling without consent. So let us see one more case. In this case, it was case of DUB previous to LSCS, and patient was for total abdominal hysterectomy. Consent was given for total abdominal hysterectomy, but on table after anesthesia, doctor decided to go for vaginal hysterectomy. And during this surgery, there was profuse bleeding at the time of ovarian stump, and laparotomy was needed because as such it was pelvic kidney, and during dealing with tubo-ovarian stump vaginally, there was severe injury to blood supply to that pelvic kidney, and ultimately abdomen was open and nephrectomy was needed. But patient was lucky, she had one more kidney and she was survived. Otherwise, a big problem would have occurred. But in this case, at the time of taking judgment, inference held by the court was very clear that bleeding may occur. Bleeding may occur at any time. Bleeding is no negligence, but deviation from route from abdominal to vaginal is not acceptable unless it is life-saving. Because patient has given consent for abdominal and you started with vaginal, and ultimately it was switched over to abdominal in given situation to save life of patient. It was appreciated. But when consent was not given for vaginal and patient doctor went with, so this case was decided again in favor of patient and compensation of ₹5 lakhs was awarded in favor of patient. One more area. Should consent be written always? Is it mandatory? Go for written consent. There are only 3 conditions by law where written consent is mandatory. One is organ transplantation. Under PCPNDT Act, sonography of antenatal patient and any case of medical termination of pregnancy, written consent is very much must. In all other consent, you can go oral consent also, but burden of proof is on your shoulder to prove that you had counsel and patient has given consent. And it is our experience that patient may go hostile in court of law that you never informed, you didn't took consent. So in this condition, though it is not mandatory except these 3 conditions, but it is always advisable to go for written consent. One more area. Should it be in English or in vernacular language? Can consent be taken by assistant doctor? Can it be taken on pre-printed form? Is it necessary to take consent in vernacular language only? So, very famous case which happened in past, RG Stone Hospital versus Vinod Agarwal. Vinod Agarwal was HIV positive patient. He had some urological problem. 2-3 hospitals denied to get him admitted due to his HIV status. RG Stone Hospital was ready. He was admitted. Consent was taken. Surgery was done. Post-operative period was totally uneventful. Patient was discharged in due course, due time. But even then, patient filed complaint against hospital that consent was taken on pre-printed form, and consent taken in pre-printed form is unfair trade practice. And unluckily, in National Commission Delhi, case was decided in favor of patient and compensation of ₹10 lakhs was awarded in favor of patient. So RG Stone Hospital was ready to pay 10 lakhs to the patient. But at that point of time, we were preparing this uniform consent and Nikhil Datar was in contact of RG Stone Hospital. So on behalf of Foxy, we requested RG Stone Hospital to prefer appeal. Because if RG Stone Hospital would have paid those 10 lakhs rupees and appeal was not preferred, then it would have become compulsory not to use pre-printed form, and we would have been compelled to use either consent in language of patient, in writing of patient, or writing by doctor and patient would have been to sign, or written by assistant doctor. But we were lucky that we could convince RG Stone Hospital and appeal was preferred in higher fora. So during the time of filing the appeal, our argument was, what is unfair trade practice? Any means in unfair way to promote business is unfair trade practice. In our practice, whether we take consent in handwriting of patient, whether we consent in writing of doctors or in writing by assistant doctor, does it enhance our practice? Court was convinced and our appeal is admitted. We are waiting for result, but till then we had asked for stay, and there is stay on that very judgment of RG Stone Hospital versus Vinod Agarwal, and we can very well use pre-printed form as far as consent is concerned. Should it be in vernacular language? It is always better if it is in vernacular language. But if at all it is in English, then at the end of consent, we have to write that whatever written above was explained to me in language which I could understand, and all the questions asked by me were answered satisfactorily, and then I have answered this, signed this document. And there should be witness on part of relative, patient, either relative or anybody else, and he will also document that whatever written above was explained before me to the patient, and then after patient has signed the document. So in this situation, even if consent is in other language, then also it will be considered valid in eye of law. So we have discussed all this. Consent can be taken by assistant doctor. Can it be taken in pre-printed form? Yes. Should be in English or vernacular language? It is preferred to be in vernacular language. But even if it is in other language, then also just I discussed, you can go like that. And as far as who will sign the document, we have discussed patient, guardian, witnesses. Should doctor sign? Yes, we have discussed already. You have to sign. As far as added consent, that is hysterectomy with salpingectomy, murmur condition, hysterectomy with salpingo-oophorectomy, cesarean section with myomectomy, cesarean section with tubal ligation. We can very well go in all this situation, but prior consent for added or additional surgery is very much must. As far as obstetric sonography is concerned, under PCPNDT Act, we are under obligation under section 5 subsection 1, we have to take consent of patient. And in that way, very consent, it is clear on part of this provision of PCPNDT Act. He has explained all known side and after effects of such procedure of pregnant woman consent. He has obtained in prescribed form written consent to undergo such procedure in language which he understands, and copy of her written consent obtained is given to pregnant patient. So we have to prepare consent in 2 copies. One it is kept to be with hospital, and 1 copy is to be given to patient. One more area under PCPNDT Act, that is invasive procedure. If we are going to go for any invasive procedure, say for example chorionovillous sampling, amniocentesis, chordosynthesis, then in this situation we have to take consent in form G. It is prescribed form under PCPNDT Act, and we have to go for consent in form G. As far as MTP is concerned, Dr. Jamuna has very specifically stressed upon that consent, and I had also explained that we have to take consent in form C, and it is very much mandatory. But again, at the same time, I had explained that we have to go with informed consent also, because if this is very simple consent, do hereby give my consent to termination of my pregnancy. So it is simple consent. So we will go with 2 consent, and it is available on Foxy website. Either you go with medical method or with surgical method. You have to simply download and to use that consent in your practice. This is part 2 of form C. If patient is minor, if patient is mentally challenged, then guardian will sign that consent form C. As far as consent forms to be maintained by ART clinic, I will not go into detail. All the forms are available on website. You go with ART Act and all forms will be available. But we will discuss only one form by couple and woman as far as form 12 is concerned. So in that very form, all the possible complications are mentioned. Nausea, headache, abdominal bloating, possibility of ovarian hyperstimulation, and if at all pregnancy happens, then possibility of multiple pregnancy. So everything is mentioned as far as complication of that very procedure is concerned. And it is also mentioned that there is no guarantee of fertilization of ovum. There is no guarantee of carry home baby. There is no pregnancy of accepting by uterus as far as ovum transfer is concerned. So everything is mentioned. And one line is also mentioned. I am aware that this will have to be in a written request. And one more area, once you have taken for any procedure, say for example, ovarian this ovum retrieval or transfer, once you have taken consent, then every time you have not to take consent again. Once consent taken, then you can go very well again for retrieval also with same consent. You have not to go for one more fresh consent. So it is very specifically mentioned in this form 12. It is for consent to be signed by couple or woman. Same way, endorsement on part of ART clinic is also mentioned in that very consent. Same way, consent for intrauterine insemination with husband in form 13, with intrauterine insemination by husband in 13, and by donor in 14. Freezing of embryo form 15. All these consent are prescribed consent, and it is available on website also. As far as freezing of embryo is concerned, I have specifically displayed this slide because it is also mentioned in unforeseen event of my death. Husband is giving consent. I would like to embryo either to perish or handed over to my wife or used for research purpose. Whichever option he has given by tick mark, it will be available and we have to strictly follow. If he have mentioned that it is to be handed over to my wife, then that embryo are available to her to go further with the ART program as far as her intending pregnancy is concerned. Same way, on part of wife, she has also to mention at the time of giving consent, either to perish or handed over to my husband or used for research purposes. So it is very clear at the time of taking consent, we should be very clear. Consent for freezing of gametes, sperm or oocyte under form 16, again in the same way, because in event of unforeseen death, embryo is prepared, embryo are stored, and before they transfer, if there is death of husband, then if husband has given consent that it can be handed over to his wife, then it can be handed over. If wife have given consent to be handed over to husband, then it can be. But one more area, if unforeseen condition or unforeseen event of death of both, then in those conditions, what should be done? For that, here it is not specified, but I would advise to specify with one line. If they are ready to give this custody of those embryo to their parents, either father, mother of husband or father, mother of wife, they can be given to them and they can go with surrogacy if they are interested in this type of situation. Or in other cases, we will have to allow them perish or they can be given for research purpose only. This is also very good part. Consent for freezing of gametes, sperm, oocyte in case of minor. If they are suffering with any malignancy or so, and if they are going to go for any radiation treatment or even radical surgery, then naturally gametes will not be available to them in future. So in this situation, they can go with retrieval with hyperstimulation and retrieval of all these gametes, and they can be stored for future planning as far as pregnancy is concerned. But in this situation, they are minor, they cannot give consent, and consent should be given by parents or guardians only. Withdrawal of consent. Patient is free to withdraw consent before surgery or procedure for which a patient has given consent. Consent for withdrawal, again there is prescribed form, that is form 18 under ART Act. Consent from oocyte retrieval form 21, for donor of sperm form 22, and consent for posthumous retrieval. This is also available in form 11. So if at all you are planning to go for posthumous retrieval of sperm or so, if consent is given, then even after death in immediate 3 hours, you can go for retrieval form for sperm. Consent for posthumous, just I mentioned. Consent for donor oocyte form 23. But this is very interesting case which was decided in National Commission C. Jaipal Reddy versus Padmini Veluri. in that very case, National Commission has very specifically mentioned that consent is not mere piece of paper where patient or patient party has to sign, but it is a very important document of your counseling, of your communication. So whatever you have counseled, whatever you have communicated to the patient or patient party, all things should be entered into that consent paper, and then patient and patient party has to sign. And once documents are signed, it becomes a documentation of your communication, and it becomes a good defense in your favor. So to conclude, I usually conclude my talk like this. This gentleman has so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. So have some basic legal knowledge and always obtain medical legal advice whenever you are in doubt, because there is always a way. So if you want to sleep like this, take tender care of your patient, take valid consent, pray Almighty God before going to sleep, and keep my visiting card below your pillow. And if this video works, this is very interesting video. Sorry, it is not working. So with regards, salute to organizers, and again to Dr. Sneha Biwar. Thank you very much. Please do not assume. Please ask if any query, any questions, if time and chairpersons permit. Thank you very much.
Thank you, sir. Sir, I would like to ask you one question, if you, Sneha permits us.
Yes.
Yeah. So, sir, what do we mean when you take a specific consent for any operation? So many people are asking me, do you have to take a separate consent for blood transfusion? Because blood transfusion or whatever complications, when we say giving blood is automatically included in that. That is the first point. Whenever we take a blood for reservation, whenever you say that the patient is for hysterectomy or for a cesarean section for APH tomorrow morning, so we reserve 2 or 3 pints of blood today afternoon. So when we reserve 2 pints of blood, it is automatically accepted by the patient also and us also that blood transfusion de sakte hain. So do we require a separate consent for that blood transfusion? And if we should take that blood transfusion consent before the case every time, even if suppose we don't require that consent later on, then what is the purpose of taking that consent for BT?
Yes. Your first query. So at the time of deciding that case of Samira Kohli versus Prabha Manchanda, Supreme Court has specifically mentioned that consent should be operation or procedure specific. So for each and every surgery or procedure, there should be separate consent, and accordingly we have to mention everything. As far as blood transfusion is concerned, case which I mentioned during my talk, I didn't go into detail of fact, but now I would mention, it was case of cesarean section with history of previous 2 LSCs. And at the time of cesarean section, 2 PCVs were transfused, and during 3rd PCV, patient went with some allergic reaction, and consent for blood transfusion was not taken. So case was filed, and allegation on part of patient and relative was, we were not explained about blood transfusion, we were not explained about all possible complication of blood transfusion, and consent was not taken. And that is why in that very case, court came up with guideline that separate consent of blood transfusion should be taken, because surgery involves risk and blood transfusion involves additional risk. That is why separate consent for blood transfusion is required.
Even if you don't utilize it later on, whenever you feel that there is a need of blood, I think we should.
If you have taken consent and if you have not transfused blood, it's fine. But if you have not taken consent and you have transfused blood, and if it is plan 1, then it becomes, if at all it is an emergency, even if you have not taken consent, then also it will do, because you can justify in court of law that it was, say for example, if it is a atonic PPH and to compensate loss, you have to go for blood transfusion or PCV rather, then no consent is required in that very situation. But if at all it is plan 1, then you have to go with consent separately.
Yeah.
Yes. Okay. Thank you.
What MC Patel sir, as usual, very
Welcome,
excellent
Girish.
talk. Hello. Yeah,
Yes,
as
yes,
usual,
Girish.
very excellent talk, sir. Sir, actually, I am having some different question. Whatever you are saying, it is absolutely right in the eyes of court of law that consent should be taken. It's okay, but there are many drugs which are having, I mean, possibility of very severe reaction. But we are not taking separate consents for those drugs, and probably, in my opinion, in such cases, blood is as good as medicine because it is transfused for the for safety and for saving the life of that patient. So ideally, it should not be like there should not be consent for blood transfusion also. It is a different story that the Supreme Court has sued one person and etc. But we are giving more danger drugs than the blood transfusion. So it is not possible practically to take so many consents for different drugs. And the intention of doctor is always good in favor of patients. So I think we are unnecessarily burdened with these consents and all papers what Shamal sir have said. And nowadays, only because of all this stuff, we are becoming clerks, and that's why probably the future of obstetrician and gynecologist is going to be very dangerous.
So, as far as this part is concerned, Supreme Court in that very case had specify everything, all this blood transfusion, sorry, in this other case, and Supreme Court has specified that specific concern for specific surgery or procedure. And that is why we have prepared. You have to simply download those consent and get it signed by patient and patient party. It is always better because it becomes a good defense in your favor. Because there are so many cases decided when either consent was not taken or consent was not properly taken, and cases were decided against doctor. And not to end up into this type of problem, it is always better, it is always advisable to get it signed as far as consent is concerned. Of course, it is little clerical burden to us, but in era of CPA, in era of all these litigations, we cannot take risk, we cannot take chance, and that is why it is always better to go with consent.
Sir, unfortunately, or whatever you are saying, it is very easy for the corporate hospital or multi-speciality hospital. But most of the doctors, specifically the obstetrician and gynecologist in periphery and even in the district places like me, we doctors are doing everything. I mean, to take the consent proper, to check the consent, to do the surgery, to arrange the blood, to talk the patient, to convince, I mean everything. So many times it's not possible to do all the things as per I mean guided by the court of law or by the law. So that this is the reason, because we don't have that much, I mean, like people with us, no, to take care of the consents and everything.
I mentioned during my talk also, assistant can also take consent. It is not necessary that person who is going to operate, who is going to go for procedure should take consent. So when you are busy, your staff can also take consent, and simply you have to verify that whether signature is there on part of patient and relative. So you can get it done that way also.
Okay, sir.
Because this type of argument doesn't stand in court of law.
Right, very right.
Person, because in simple way, in one of the cases, argument was like this: we are very busy person. So argument on part of court was, if you are so busy, then you can afford one more staff. So you hire one more staff and get it done by that staff. If you are not so busy, then you can do it by your own. So there was argument on part of court. So we have to follow.
Yes, sir. Yes.
These are some professional hazard, Girish, and we have to go with.
Yeah, exactly, sir. And there are you for us, so we don't need to worry.
Thank you.
Dr. Mane, that is not an excuse
Prakash sir.
not to take
Yes, sir.
consent
Prakash
because you
sir,
are
I can
alone.
understand.
It is right.
No.
Ours is a one-man show, but you can't help it.
Yes.
Exactly, sir. Sir, I do agree. Just I'm expressing my sorrows for the liability of doctors in future. I understood what that thing. Over to you, Sneha, madam.
Yes, yes. So that was, in fact, good, Girish. You expressed thing on behalf of the obstetrician community. So thank you so much, MC sir. I have already written for you last word by MC sir. So wonderful as always, and definitely uniform consent. You know, that's a gift from all of you to Foxy. I would say the entire community of obstetricians. So we are very thankful to you, sir, and you will be remembered always for that uniform consent. So definitely you are a helping hand for all of us, just a phone call away. So we are very privileged, and we wish you a long and healthy life, and of course best wishes for your presidential elections next year. With this, I would like to thank the God Almighty and the respected seniors, especially the chief guest, Madam Kamini Rao. In spite of being so busy, she joined and expressed herself. Guest of honor, Madam Anita Singh, Dr. Prakash Pawar sir, and Dr. Gokul Das sir. All the speakers, I thank all of them already personally, but I would like to thank all the speakers and chairpersons from the entire team. Thank you so much. And I take this opportunity once again to humbly seek all of your blessings and wholehearted support and votes. I hope, with your support, I win this election. Though winning the election is not a prior aim, I continue, sharing knowledge. Thank you so much. So thank you so much, everybody.
Thank you.
Any comment from anybody?
Thank you.
Thank you. Thank you so much. Thank you, Ashwin, Alka, Prakash sir.
Thank you, ma'am. Thank you, sir.
Thank you so much.
Thank you, ma'am. Thank you for the opportunity.
Thank you, Girish Kumtekar sir. Thank you, Saiti. It was flawless. Thank you so much.
प्रकाश सर जी कैसे हैं?
I think sir just left.
Just left.
Yeah. Thank you, sir. Thank you, MC sir. Good night.